And it's my pleasure to invite Dr. Santosh Kumar Singh, endocrinologist from Patna. And I always tell in any scientific meeting that he is encyclopedia of medicine in general and endocrinology in particular. Over to Santosh for his presentation on NAFLD and CKD, the deadly duo.
Thank you, sir. Thank you, chairpersons, dear friends from outside and the city. A very long talk, so when the timer rings, I will stop. Very many slides are there. I tried myself to abridge those, but couldn't. So let me see how many I can cover in the 17 minutes. Diagnosis, this is known to us. Initially we used to talk of non-alcoholic fatty liver disease. Now we talk of the metabolic dysfunction associated fatty liver disease. And this is again a slide CRP. Again, a very interesting part. And lower down you can see it doesn't exclude alcohol. So it is encompassing all the things which can produce liver dysfunction. So this is the metabolic dysfunction. This is all known to you, how to categorize patients, classify patients according to the FIB-4, and then you go for the elastography test to categorize and for proper treatment and proper referral as we do in kidney patients. This is the kidney. We are talking about NAFLD and CKD, and as you can see the different risk factors we are well aware of: dyslipidemia, hypertension. Lower down you can see a mention of MAFLD. This is important, and this should be our day-to-day practice. Always repeat the test to put the patient in the category of CKD. And we all know it is EGFR and the ACR thereof. And we have different practical implications of doing the EGFR by the MDRD and CKD EPI, because those two are depictive of two different outcomes. One is linked with the CVD outcomes, the MDRD, and the CKD progression is nicely depicted by CKD EPI, which we will find in majority of the labs giving these values. But important in this slide is to repeat the test. This is the treatment part, and this we are well aware of in present day precision medicine, the different types of diabetes. First one is type 1, synonymous, and then we have the insulin deficiency. We have SIRT, which includes significant insulin resistance. We have mild obesity-related diabetes and mild age-related diabetes. Don't go by the term mild. They are all associated with complications. Okay, but the third group, you will find a mention that it is associated with both the two things, which is the present day talk about fatty liver disease and CKD. This is in children. Just look at the implications of obesity and the type of diabetes they can develop. Okay, and the first part is the LADA, which we are talking about the autoimmune diabetes. And here I have mentioned about the incidence of NAFLD in this category of patients of type 1. These are typically LADA patients with an age group of 35, BMI of more than 28, and they have been found to have NAFLD to the tune of 70% and more fibrosis, and the fat area were APRI, the index of more than 0.7, and we all know FIB-4 like in adults more than 2.67. So in that category of patients of type 1, and we have talked about the lower 4 in the previous slide. These are the genetics of the implications of insulin deficiency, and then we have the liver lipid metabolism lower down. And if you are versed with the NAFLD, you will easily guess that the lowest part is again linked with progression of liver disease, which you will see in a subsequent slide. Now we come to the epidemiology, and this is known to you all. Diabetes prevalence 11%, and for this entity to the tune of 30%, it goes to almost 70% in the diabetics, it goes to almost 100% if the diabetes is obese. So this is the present day prevalence. Similarly for the CKD, and this is a study correlating BMI with EGFR and not so with proteinuria. So this is a very important aspect of the association of obesity and CKD, like we saw in patients with NAFLD, the contribution of obesity. Now burden of NAFLD, you can see the different risk factors again, the different components of metabolic syndrome, but we are interested in more common in Asians. Okay, and lower down is just the definition of NAFLD which we started with. This is the Indian data. Prevalence in India 38%, and lower down you see the prevalence in children, and this is very alarming. We are day in and day out coming across children having this problem and are coming with type 2 diabetes, and this is very important from this aspect. This was a prospective study showing, look at the last line. Incidence of type 2 in children is 30 times greater than previously reported pediatric populations, and implications is patients with NAFLD. And yesterday I talked about the Masala study, and there the implications of visceral adiposity linked with all the different stages of the DBCD, dysglycemia-based chronic disease, including pre-diabetes, diabetes, and the complications. But the conversion from pre-diabetes to diabetes is mainly implicated by the presence of hepatic fat. And that is very important aspect, and we need to curtail this hepatic fat for overall benefit of the patients. Youth onset diabetes, and here you can see it has a more aggressive course in the youth of fatty liver disease. And on the right hand side you can see implications of, if you can take care of obesity, you can definitely impact, that's the last line on the kidney part, you can impact the kidney function decline with bariatric surgery. Now this is again interesting. The NAFLD risk 5-4 linked with incidence, CKD incidence and progression. This is another study. Just look at the last line again. 31% patients developed stage 3B CKD versus non-NASH patients of only 8%. So again, almost 4-fold increase in the incidence of CKD dysfunction in patients with NAFLD. This is the incidence, and this is all known to us from the Indian study. 21% EGFR, 61% including both EGFR and ACR. And here again you have the conditions linked with advanced fibrosis, and we have the male gender, and as we talk of 2020 as a COVID-19 year, we will be talking about ChatGPT in the year 2023. And this was just surfing the cause of increased fatty liver disease in males versus females. And the answer was, it is linked with visceral adiposity, which is more common in males compared to females. So there is the male gender, and definitely I was embarking on the ethnicity part. Asians have a more progressive course, be it NAFLD, be it CKD, and hence the choice of proper drugs, which we'll be talking about in the subsequent slides. This is a very nice study, and study also I talked about the variability part, the blood pressure variability, the glycemic variability linked with the complications, and here is a study associated with CKD function decline. And interestingly, you will find the variables which are associated with glycemic variability, again the Asian ethnicity, BMI of more than 30, and higher systolic blood pressure, longer duration of diabetes. So there's the usual things which we always correlate in our mind with advanced degree of complication in diabetics. Again here you will find a mention of CKD, interesting aspect, prevalence is more in females, but the incidence and CKD decline is more common in males. The importance again of SHBG, and again the male-female differences which we have, very nice study. On the right hand side you will find the intermediaries, how it is linked with increased glycemia and the complications thereof, and very nice one. And this is the renoprotective effects of the female hormones on DKD, and that was is one of the reasons why we have less progression of CKD in females compared to males. And almost all, you talk of the estrogen receptors, you talk of progesterone receptors, and not only that, even the benefit of HRD in combination, and the pathways, you can see it is acting on the tubulointerstitial cells, it is acting on the NRF, it is acting at the KEEP, lowering of KEEP, which is associated with renal injury. So majority of the aspects are affected by these female hormones, producing better effect, lesser decline. This is the crosstalk, and here we have the implications of NAFLD with the different complications. And we have talked on the gut microbiota. It's linked with the skeletal muscle resistance, the saturated fatty acids acting on the GPCR receptors in the muscles producing insulin resistance, and the whole lot of complications now linked with the gut microflora. And in this slide I have deliberately just have a look at this. On the right hand side you will find a mention of hepatic glucagon resistance. And this is very interesting aspect, and the link is this. Hepatic glucagon resistance, and you can see the implications linked with hyperammonemia, increased hepatic fat, increased oxygen stress. And if you remember the initial talk you used to talk of insulin resistance, oxygen stress, and the cytokines linked with fibrosis. And look at the contribution of glucagon on this hepatic fat and oxidative stress, and how it can impact. And if we can lower this, it can be beneficial for the hepatic health. This is just in brief about the the glucagon resistance. This is another study. The usual effect of glucagon is to secrete triglyceride from the liver to the bloodstream, and if there is glucagon resistance, there will be accumulation of this one, and the suppression which is not there, there will be increased VLDL secretion, increased triglyceride which will lead to atherogenesis. So the glucagon suppresses this. If in the presence of glucagon resistance, this will be aggravated. And on the right hand side, you will find we have this fatty liver index, which is depicted by BMI, waist circumference, gamma, GTP, and TG. And interestingly, these are the variables which are affecting the glucagon resistance. Okay? This is the liver fat effect of liraglutide. Very recent study, and the impact of this molecule on reducing the glucagon resistance. We are well aware of the hyperglucemia which can happen in patients with CKD, and interestingly, presence of increased glucagon has a detrimental effect on the kidney health. It increases, produces kidney hypertrophy and all. So we are like insulin, we are having resistance at one point and overactivity at other point. So if you can take care of the hyperglucemia, it can be beneficial. This is the kidney function. And now this again aspect, I made a point on thyroid hormone resistance and the implications in liver disease. We are now having specific drugs to counteract NAFLD with the TSH receptor beta, and this is the data. The TSH receptor beta in NASH, and this can be again ameliorated by liraglutide. The impact on thyroid hormone resistance. We are well aware of low T3 and the implications on progression of fatty liver disease, and we all know CKD is a thyroid hormone resistance state with low T3. So just imagine the associations of all these and the complications of the duo which we are talking about. This is the effect of empagliflozin on gut microflora. This is a study vis-a-vis metformin, and EMPA definitely scored over metformin in all these aspects, even in 1 month time. The effect of sarcopenia in NAFLD, and we all know the associations. In the first slide, if you remember, we talked about the gut, we talked about renal dysfunction, we talked about the muscle sensitivity and the muscle power, which can impact the different complications. And look at the contribution of the gut microflora in all these associations. Now, recent data again, EMPA versus PIO. And we all know if we talk of present-day treatment of NASH, it comes to pioglitazone. This is a study where it's a comparison with EMPA versus PIO, liver steatosis and fibrosis, both were reduced, and interestingly, there was no change in skeletal muscle mass. Okay, so this group of molecules, SGLT2 inhibitors, apparently it seems that they will be producing sarcopenia, but studies have shown they don't impact sarcopenia, and this is a study which highlights the same. Now we come to the important aspect. These are the causes of death in NASH. So it is cardiovascular death like CKD, which is on the higher side, non-liver malignancy and liver disease. I remember the percentage as 3, 5 and 15. Okay, and then we will be talking about this aspect, whether effect or epiphenomena. Look at the intermediaries which can lead to atherosclerosis. We had a nice talk on ASCVD yesterday. This is just a recapitulation of all those mediators. This is a study by Kamlesh Kunti, and these are naive patients. They didn't have CVD. And look at the contribution of CKD in CVD. And this is known to all of us. And the cardiovascular events, the death, which is at par with patients with established CVD. This is the association. With a higher grade of lower EGFR, we have more twofold increase in the MACE and heart failure, and almost tenfold increase in renal function decline. So if you can impact on this, definitely it will produce long-term benefit. Now you have the URA effect on the lower side, and this is just the contribution of uric acid in the renal function and the hepatic function decline linked with fibrosis. And here we have again different clusters of hyperuricemia. In this cluster 3, again you will find a mention of diabetes and increased liver disease. Okay, so this all these entities are linked, like we all know the association of hyperuricemia with kidney function decline. Okay, and this is the data which we have with empagliflozin. Irrespective of the uric acid, we are having the cardiovascular and renal benefit. So these are, I have put a star on choosing drugs which can impact both these entities of NAFLD and CKD, and the intermediaries which we are talking about. These molecules are taking part in all the things. If you remember the initial, the empiric study and the mediation analysis, it was mainly the hematocrit, and then we have uric acid, and then we have glycemia. So it was like that. So different aspects producing the benefit. This association is also known to us, the association of FIB4 with reserved ejection fraction. And this is the renal impairment, we all know it's linked with heart failure. This is the association with heart failure of patients with CKD and MAFLD. But this is obviated when the patient is having albuminuria. So if a patient is having lower eGFR and MAFLD, the link is the same as we will have with advanced ACR. This is the contribution of ACR and eGFR, and the way I remember 4, 16, 24 and 48, the 10-year mortality. ACR, eGFR and the combination. And absence 4, then you have 16, 24 and 48. So all of you can remember the data, 10-year mortality, a bit lesser with albuminuria only, more with the combination. The link with NAFLD and severe hypoglycemia, very interesting again. On the right hand side you will find explanations. Again the pinpointing the hyperglucagonemia, and this is linked with the glucagon resistance, where you will be less of the response which we have in escalation of glucose after a hypoglycemic episode. And if you know, we talk of amino substrate in patients with type 2, there is amino substrate in type 1. And one of these is glucagon failure with time in type 1 diabetes. So this is almost synonymous with that. We have more of severe hypoglycemia in patients with NAFLD, that is linked with glucagon resistance. More in females, and we all know the estrogen sensitizing effect of insulin. Okay, so now I have to rush. Severe hypoglycemia known to you in CKD. The management part, this is, as I told you, PIO followed by SGLT2 inhibitors and GLP-1 receptor agonists for their cardiovascular and pleiotropic benefits. The blood pressure, blood glucose targets we talked about. The NAFLD, the statins, and the commonality in between liver disease and CKD is the statins. You should have a caution in patients with decompensated cirrhosis like we have in patients with CKD. Okay, the statins we don't start in patients afresh with patients on hemodialysis. If you are taking, you can well continue. This is the study with PIO, and on the right hand side you will see this was a recent study compared with gliptins, and the cirrhosis of liver, hepatocellular carcinoma and end-stage kidney disease was less with PIO compared to the gliptins. And this is just to highlight the present day scenario, how we are dealing with the duo. SGLT2 may improve outcomes in patients with cirrhosis, and this is the study now we are very much satisfied with, the SGLT2 inhibitors versus PIO reducing FIB4. And this is just to highlight the recent data where we can definitely position SGLT2 inhibitors and at par with pioglitazone in day-to-day management of NAFLD and avoidance of CKD. Insulin, end-stage liver disease or kidney disease, insulin is the answer. These are the putative mechanisms. And we will straight away, this is the benefit you reap from the addition of phenomenon with SGLT2 inhibitors, definitely almost triple-fold benefit, and the outcomes linked with eGFR, CVD, albuminuria with heart failure and cardiovascular mortality. And I was talking about Asian part. Look at this data, GLP-1 receptor agonists and SGLT2 inhibitors scoring not only for glycemia but also CVD, CKD outcomes in Asians, more so in the global population. Now take home message, I have talked much. Two things I would like to highlight. Just keep in mind the association, not only keep SERD and these things in mind, in day-to-day practice we will be versed with selecting patients, properly diagnosing them, repeating tests for a proper evaluation of CKD, and managing them and regarding their progression from further progression. And this is the choice of drugs which we can do for both these entities. Thank you all for the patient hearing.
Hello, yeah. Can we have questions? We can have 2 questions for sir.
I would like to have any direct correlation of the liver fibrosis scoring with the complications like cirrhosis of liver 1 in respect with diabetes.
I showed you the slide. I think
You just passed over very quickly.
no, you see, I had a slide on the mortality data, okay, and that is CVD mainly, followed by the malignancies, non-liver malignancies, and then we had the liver disease progression as such, okay. And with a FIB-4 of more than 2.67, definitely it has been correlated with advanced fibrosis. Okay, and if you grade by that elastic fibrography, you have that criteria of 8, 8 to 12, 12 to 16, more than 16. And that finally correlates with the FIB-4 score. The associations I showed you, the 5-4 linked with the progression of even CKD. So these things are all related, and in the intermediate you will find mention of inflammatory cytokines. If you talk of all these and one single factor, you will find different cytokines elaborated in a greater way and impacting all these things. And then we have the metabolites which we talk of this. But I would, if you talk of one answer, I would give cytokines the primary answer.
So one question from my side. So so non-diabetic, obese, NFLD, the drug of choice like Bio or Empa, non-diabetic, NFLD, obese.
There was a study with Taheri, okay, and that's a single study. But if you talk of present day data, I would score Bio over Empa in non-diabetic, present day. Okay, but now the studies with Taheri is a study in non-diabetic population, and the benefit of these molecules in non-diabetic CKD patients, I think these molecules will be going at par.
So I thank Dr. Santosh Kumar Singh for an excellent presentation. A big round of applause for.
Thank you. And a question to the chairpersons, any idea how many slides were there?
60, close to 60.
It was 90. Thank you.
Sir just told me if you have a 20 minutes talk, think of 40 slides, not more than that.
He goes with the slide. He will just pass you off. But we is the go get up the slide.
मान लेना है सर
बोल रहे हैं ना वही हो गया.
Yes, sir. Yes, sir. Heartiest thanks to the chairpersons and the speakers. May I request the first speaker also, Dr. Shyam Kishore, sir, to please join come on the dais. I request the chairpersons to honor our first speaker, Dr. Shyam Kishore Prasad Singh. He gave the wonderful talk. He was the opening batsman for the day. Big round of applause for sir.
हो गया कल हो गया था
Can we have a bouquet and for bouquet and
खाली पड़ जाता है नगर जी हालांकि साल तो पहले ही आपका काम पड़ गया था है ना सोने चाहिए
नहीं sir, we can have sir.
अरे सर कम नहीं है. इसको बहुत बड़ा दीजिए.
Thank you.
आइए अरे सॉरी
Can we have a bouquet for chairperson?
एक चेयरपर्सन को तो शॉल तो पहला होगा सर को आप दे दीजिए
Request the speakers to please honor the chairpersons.
मुझे लेक्चर में देने के बाद पहले में अच्छा था
Please, एक बुक है अभी ले लेंगे.
हाँ मुझे अभी दे दीजिए फोटो खींच भाई
Big round of applause. पीछे लोग सुस्त हैं. Big round of applause सर के लिए. Thank you, sir. And to begin with the proceedings for the second session, may I request chairpersons for the second session, Dr. Sujoy Ghosh and Dr. Supriya Mukherjee. Dr. Supriya Mukherjee. Yeah. And they will invite the speakers for the second session.
A big thank you to the organizers for firstly giving me this opportunity to come over to Bhagalpur and be part of this academic feast. So after the first session, we move on to the second session where we have a talk by Dr. Ajay Kumar. Upstream approach in the management of diet.
No, that's Ajay Chhabra.
Harmonious blend of various oral hypoglycemics in type 2 diabetes, tipping points, and I think this audience does not need any introduction for Dr. Ajay Kumar.
Honorable Chairperson, Dr. Supriya Mukherjee, ladies and gentlemen, a very good morning to all of you. It's an absolute pleasure coming to your alma mater. Many of you might not be knowing that I'm a product of Bhagalpur Medical College, second batch of this medical college, and it's really a great emotional feeling coming to the institution. I have a conflict of interest for this talk. My talk has been sponsored by Boehringer Ingelheim. We all know about type 2 diabetes, that there is a huge prevalence of type 2 diabetes, and consequent upon this huge prevalence, automatically we look at a humongous burden of long-term microvascular and macrovascular complications. And when you deal with huge numbers, and particularly those with complications, there is a lot of money involved in treating these patients. And unfortunately, our experience so far has been that compliance and adherence of treatment and achieving the target on a long-term basis is a big challenge in the practice of diabetes. Do we have the data for what I am saying? This is the data published by Dr. V. Mohan and his team. Dr. Vinay Dandania was one of the investigators who is just present here. I think he just gone out. Oh, he's here. And this was two parts study. In the first part, Jharkhand was there. So Vinay is in this paper. In the second part, Bihar was there. I was the principal investigator for Bihar. But this is basically in-diabetes study looking at the entire gamut of prevalence and management patterns, dietary habit, and everything in patients of diabetes in India. Now, what evidence did we get from this study? And this is a hardcore Indian data and a study done extremely systematically in a very scientific manner. Now, look at the percentage of people who achieve the target, whether you talk of the A1C target or BP target or lipid target, or what percentage of patients are taking oral drugs, what percentage are taking insulin. The entire issue related with type 2 diabetes management was looked at, and particularly when you look at the HbA1c, it's less than 40%. Is it good, bad? I remember I was also part of Diabcare India study in 2011 and subsequently 2017, and at that point of time, only 17% of the patients achieved the HbA1c target. So now if in diabetes study we are demonstrating that we have close to 35%, I think it's a significant improvement, and we should congratulate whatever we did over the last 3 or 4 decades in terms of spreading the message of scientific management of diabetes, I think it is now bearing some fruit. And if we carry on disseminating the scientific knowledge, up-to-date knowledge, I am sure these percentages will improve in future as well. Because we clearly know that increasing HbA1c is very clearly associated with increased risk of all-cause mortality and cardiovascular mortality, both in people less than 65 years of age and more than 65 years of age. There is absolutely no confusion. And we also know that if you keep giving one medicine to a patient, its efficacy will decrease over time, as you can see very clearly in this particular slide. And then many a times we are led to believe कि भैया 1 gram के बदले 2 gram, 2 gram के बदले 2.5 gram, 3 gram. We go on increasing the dose of metformin, but beyond a certain point you will see that it will only increase the risk of side effects, but will not contribute to further reduction in the HbA1c, and this is extremely important. And therefore it is imperative on the part of the clinicians that rather than continuing with a single dose and increasing single drug and increasing its dose, it is better to use a combination therapy much early in the natural history of type 2 diabetes, because we have very clear data, as you can see here, that if you escalate the treatment much early, then you can see here that those patients with early intensification are doing much better with those with the late intensification, whether you talk at 6 months, 12 months, 24 months or 36 months. So a very clear message that you should be actually combining the medications much early in the natural history, because when you will combine, you will be targeting most of the pathophysiological mechanisms. But more important is to select those agents which have not only glycemic benefits but also non-glycemic benefits in terms of cardio-renal protection and other issues. And at the same time, they should not be inducing hypoglycemia or weight gain. And compliance is a big issue which can be achieved by many other ways, but one of the ways is to reduce the pill burden. When we have these hardcore data, then we have to look at the disease itself. And we all know that type 2 diabetes has a common soil factors, risk factors like diabetes, hypertension, obesity, and then it moves on to microvascular and macrovascular complication, and finally to the end stage disease. Let's take a real life patient, and we start this patient, our reference patient, which is in the early part of this metabolic cardio-renal continuum. If we do not intensify the treatment very early in the course of the disease, we are expected to have a worse progress of the disease and leading to poor quality of life and development of long-term complications. This is our reference patient, Mr. Sanjeev, 42 years old, has a family history of cardiovascular disease. Otherwise, at this point of his first presentation, he doesn't have any concomitant condition. A1C is not very high, 7.2%. Fasting 120, 170, lipids are normal, eGFR is 110. So when you look at the current guideline, the guidelines clearly tell you that this type of patient should receive this treatment. This is a small print, so I have made the next slide which is a bigger print. So first line therapy depends upon comorbidities, patient-centered treatment factors and management needs, and generally includes metformin and lifestyle modification. So as per the guideline, this patient was given metformin, and metformin is a wonderful drug and it works. If we carry on following these guidelines, the same patient comes 10 years later. He was 42 then, now he is 52 years old, and remember, he had a history of family history of cardiovascular disease. Now in last 10 years, he had a myocardial infarction. He also developed hypertension for which he is getting treatment. His LDL is 120, and now at this stage, he has diabetes, hypertension, and a history of myocardial infarction. So again we go to the guideline, and now the guideline tells you that in presence of atherosclerotic cardiovascular disease, you should be using a GLP-1 receptor agonist of proven cardiovascular benefit, and beyond GLP-1 receptor agonist, you can use an SGLT2 inhibitor, or if one fails, you can add another. Right? This is the guidelines which tells you that now this patient needs or qualifies for this kind of combination. Please listen to this very carefully. Now, 10 years down the line, when the patient has developed hypertension and a heart attack, now he qualifies for this combination treatment. as per the guideline. And of course, vice versa, if the patient is started on SGLT2 inhibitor, you can add GLP-1 receptor agonist. Now the same patient, another 10 years down the line, now develops heart failure. And again, the LDL is still not on the target, blood pressure is quite reasonably controlled. And now once again look at the ADA guideline, and that tells you that because the patient has got type 2 diabetes, hypertension, history of myocardial infarction, heart failure, so now you have to give SGLT2 inhibitor. In heart failure, SGLT2 inhibitor takes precedence over GLP-1 receptor agonist. And then if of course SGLT2 inhibitors are not alone enough, you can again add other drugs. So this is the guideline, and now the patient goes from heart failure to kidney failure. The patient is in CKD now, as you can see here. The eGFR has now dropped to 30. LDL is now on target. Again you refer to the guideline, and now same guideline, what it tells you here. Patients with chronic kidney disease, with albuminuria, without albuminuria, with albuminuria, it is clear cut. GLP-1 receptor, with albuminuria, you have the SGLT2 inhibitor, without albuminuria, you have the GLP-1 receptor. Or again, vice versa or combination. All of you know this, that this is the current guideline. So what have we done with this patient? We have treated this patient for 30 years with the guideline, very clear recommendations, and we have allowed this patient from a type 2 diabetes, which was uncomplicated, to develop hypertension, myocardial infarction, heart failure, and chronic kidney disease. So, can we change this entire scenario? This presentation is not a scientific presentation from my part. It is only a thought-provoking question that I am asking to all of you. So now our friends, Sujay, I hope Sujay is also in this study, Dr. B. Mohan, Anup Mishra, Manoj Chadha, A.K. Das, all big names are there in this particular study. This is an expert opinion on the use of combination therapy right from the beginning. So a fixed dose combination of SGLT2 inhibitor and DPP4 inhibitor, remember, if you combine these two or in place of DPP4 a GLP-1 receptor agonist, it will address most of the pathophysiological mechanisms of type 2 diabetes, and therefore it is a very good combination. So in the different clinical scenario of type 2 diabetes, scenario 1 and 2 purely based upon the glycemic blood sugar level. Scenario 2 with cardiovascular disease, scenario 3 chronic kidney disease, and scenario 4, whatever the situation, avoid weight gain and hypoglycemia. And the good thing is that for every scenario, scenario 1, we have the data that this combination is better than the individual molecules. We have the data for scenario 2, once again, much better data with the fixed dose combination. Again, we have very clear data that it is not only effective, but it has got a very long durability of action, which is so much desirable in patients of type 2 diabetes. Scenario 3, once again you see that there is very clear data that SGLT2 inhibitor empagliflozin in the EMPA-REG study clearly demonstrated the benefit in terms of 3-point MACE, overall mortality, cardiovascular mortality, heart failure, hospitalization, and DPP4 inhibitor linagliptin was neutral for all these things. So an excellent combination, one drug giving you all the benefits, other being neutral, so no question of any harm, and therefore this is a perfect combination to be used in this kind of scenario. And then when you look at the other aspects of this EMPA study, they also used empagliflozin in patients with reduced ejection fraction, normal ejection fraction, diabetic patients, non-diabetic patients, and consistent benefit irrespective of the baseline that you are talking about with SGLT2 inhibitor empagliflozin. Now coming to scenario 4, patients of chronic kidney disease, once again we know huge benefit with SGLT2 inhibitor in chronic kidney disease. And in fact, when you combine empagliflozin and linagliptin, the fibrotic markers, glomerular fibrosis, which will be progressive, is clearly prevented by using this type of combination. And in fact, an EMPA-LINA combination has not only shown a reduction in the HbA1c, but also favorably affecting the renal biomarkers, oxidative stress markers, and so on and so forth. Clearly, not only the endpoint result, but we also know the mechanistic explanation. And also we know that in the linagliptin carbolina study, it was neutral. So you are talking about either benefit or neutrality with this combination, and therefore absolutely no risk. And this is the KDIGO algorithm for management of type 2 diabetic patients with chronic kidney disease, physical activity, etc. But you will clearly see that metformin, depending upon the EGFR, and then SGLT2 inhibitor occupying the top position. And if that is not enough, you can use a GLP-1 receptor agonist. If the patient cannot afford, you can use a DPP-4 inhibitor, because cost is an important factor with GLP-1 receptor agonist. And once again, when we talk about avoidance of hypoglycemia and weight gain, we know that DPP-4 inhibitors are weight neutral, do not cause hypoglycemia, and SGLT2 inhibitors give you the benefit of weight reduction. So a very good combination. Now, when we talk about long-term adherence in patients of type 2 diabetes, in the real world, we would expect this, if everything is fine. But what actually happens is this. So there is a huge gap which we can address by doing something. And what is that doing something? I think the Shyam also talked about the pill burden, and once again I am showing you the data that it is inversely proportional. If you are asked the patient to take one drug daily, the compliance is obviously much better than if you ask the patient to take 3 drugs or 4 drugs or 5 drugs, which is absolutely clear. So dear friends, I would like to conclude my talk by telling you that early and more rapid achievement of glycemic targets, but not only achieving the target, select the agent very properly which has got complementary modes of action and actually not only target all the pathophysiological mechanisms of type 2 diabetes, but also provide the cardiovascular and renal benefits. And to improve the compliance, simple regime, maybe just 1 tablet a day should be fine, and potential reduction in dose-related adverse effects, because if you go on increasing the dose of metformin too much, it will lead to a lot of side effects. So this type of treatment approach is very nice to delay the disease progression, which unfortunately our reference patient passed on from one stage of complication to another, and we just kept on following the guideline. So my last question is metformin now the first line agent in treatment of type 2 diabetes? I personally think, and even the ADA now thinks, that metformin is no longer the first line drug in all type 2 diabetic subjects, and maybe all type 2 diabetic subjects to start with should be given 1 pill of a combination therapy of SGLT2 inhibitor and DPP4 inhibitor, and maybe even a statin, because you remember the Steno study published so many years ago clearly showed that type 2 diabetes is a metabolic disease, and target all the metabolic aspects of this disease process, and possibly then you will derive the maximum benefit of treatment. So maybe we need to have a changed attitude towards treating type 2 diabetes. We will need scientific data to corroborate what I am suggesting. It will take a long time. Thank you for your
Thank you, sir, for that excellent presentation. So, just a hypothetical question perhaps. So, if you have to start with 1 drug, would you want a triple drug or do you want a dual drug?
Dual.
Keeping the metformin in or out?
Out.
Right. Okay. So, any questions from the audience?
If the patient
Yeah.
is not suffering from renal disease, in that case, metformin should be added on. Should be the first drug.
My question was, why should we prescribe metformin? What is data with metformin? Metformin is a good drug to control blood sugar. It doesn't have a dedicated cardiovascular outcome trial. It doesn't have a renal protection benefit. Its dose has to be modified. It leads to a lot of gastrointestinal side effects. Only 243 or 342 patients from UKPD subgroup study has shown that metformin was beneficial in terms of cardio. So why should we use metformin?
Metformin is the insulin sensitizer drug, sir.
It is,
And it reduces the resistance.
right? Correct.
If the person has the reduced resistance, in that the metformin is a drug.
Okay, so his question is that the basic pathophysiological mechanism of type 2 diabetes is insulin resistance. So first let me tell you that the quantum of insulin resistance in type 2 diabetes is 33% in liver and 77% in muscles and adipose tissue. Metformin doesn't address insulin resistance in muscles and adipose tissue, it only addresses the liver. So if you want to use an insulin sensitizer, use a pioglitazone. Why metformin? So I don't see any reason in my practice to use metformin at this point of time. This is a very volcanic statement. I do appreciate, I agree that what I am talking is not pure science. But I have a contention, I can argue on this. You said that you will target insulin resistance. So target with pioglitazone. It will give you 77% success. Metformin will give you 33% success.
One question more, sir. If the person is suffering from type 2 diabetes, the first thing to see that is suffering from macro and microvascular complications. If there is microvascular complication, in that what should be the target of HbA1c?
Right.
And if the patient is not suffering from microvascular, what should be the target of HbA1c?
I think this is very clear that not only microvascular complications, but so many factors have to be taken into consideration. And there the ADA guideline individualization of treatment factors, what is the patient's age, whether there is high risk of hypoglycemia, whether there are comorbidities, whether the patient has got family support, etc., etc. Depending upon, we set up a stiff target or loose target. Any target, when you look at the overall mortality benefit in type 2 diabetes treatment, the best outcome is between 6.5 to 7.5% of HbA1c. For majority of patients, that will be the targets. Less than 7%, younger patient with absolutely no comorbidity, less than 6.5%. With number of comorbidities, 7 to 8%. With malignancy and terminal diseases, 8 to 9%. So these are individualized targets. And therefore, if a patient has got just beginning of microvascular complication, less than 7% should be fine.
Sir, sorry.
Yeah.
According to your that hypothetical, that was not a genuine case, Mr. Sanjeev, I think. So we allowed the patient to pass into so many complications and finally losing their life with that ADA algorithm. So do you have some insight that in future the first guideline, which is metformin and lifestyle modifications, may be totally eliminated from those algorithms, keeping in view the virtues of SGLT2 inhibitors and DPP4 inhibitors at the first place to protect the complications.
This is a work in progress.
Yeah.
This is a work in progress. 23rd November 2022.
Yeah,
Just
yeah.
a few months ago, ADA has accepted that metformin is no longer the first line treatment of type 2 diabetes, and in large number of patients you can start treatment with SGLT2 inhibitor or GLP-1 receptor agonist or a combination of these two molecules.
Yeah, one more question, sir. Empalina or Sita-Dapa?
I think the most robust data is with Empirelina.
Yeah.
There is absolutely no confusion about it because all others have one or the other deficit in their respective trials.
Definitely.
But having said that, I do appreciate that these trials were in different study population. It is like comparing apple with oranges. If you do this, all the studies with the same baseline characteristics, then it can be comparable. But you remember that in EMPA-REG study, 99% had patients were high-risk cardiovascular patients, whereas in the DAPA study, it was 60% and 40%. So the baselines were not the same, and therefore we cannot actually come to a concrete conclusion that they are exactly the same. But at present time, I think empagliflozin has the best data. There is no doubt about it.
Yeah, but looking to the declared trial and all, DAPA is more having heavier.
You are very correct. I agree.
Yeah.
If declared trial also had 99% patients with high risk, maybe they also would have met the 3-point MACE criteria.
Yes, sir.
But they had only 60%. Think of it.
But other thing for Lina is the CKD.
Yeah.
So certainly this DAPA and this DAPA as well as Lina can be a good combination.
Absolutely.
Do you think?
Not only that, if a patient cannot afford a fixed dose combination, use any combination of SGLT2 inhibitor and DPP4 inhibitor. अरे कितना जिसको हम लोग हिंदी में 19-20 का फर्क करते हैं, मान लो कि एम्पालिना तुमको 20 दे रहा है, वो 19 देगा 18 देगा, but still my patient will be benefited. So I am quite good by using any SGLT2 inhibitor plus a DPP4, but they should be the good ones.
Yeah.
Linagliptins, sitagliptin and vildagliptin. Maybe going beyond, I will be hesitant.
Yeah.
Empagliflozin, canagliflozin and dapagliflozin. Beyond that, difficult.
अब से संजीव साहब नहीं, उनको कुछ नहीं होगा.
Thank you so much.
Out of these linagliptin and other gliptins, which one you prefer exactly?
I write all three of them, to be honest. All three of them, depending upon my patient's affordability.
Okay.
At this point of time, linagliptin is the most expensive, right? So if I find that my patients can afford linagliptin, I go ahead. Patients with renal problem, patients with hepatic problem, we know that no dose modification. So you have a comfort zone with linagliptin. So linagliptin becomes that choice, at that point of time.
Some prescriptions we have seen linagliptin 2.5 milligram. Is it correct?
No, I don't see it. I was the investigator of
I have seen the prescription by diabetologists.
No, there is absolutely no point.
Just they break it up and
What is the
right,
point?
and there's a now second is that we talked about the renal glomerular fibrosis and all that. Concomitantly we have got liver fibrosis and fibroscan reports are higher side, elastographic reports are on the higher side. Now what will be the combination? Is it the same combination?
Very nice question. I think Santosh talked a lot about it, that pioglitazone SGLT2 inhibitor benefit. You go back to our lecture some 5-7 years ago, we had huge amount of data with sitagliptin, that it reduces the liver enzymes, it reduces the fibrous score and everything. So we do have data with sitagliptin also. We have data with linagliptin also. So I think it is your choice. And when you have other reasons to have a compelling indication to use combination therapy, any, between sitagliptin and linagliptin, one DPP4 inhibitor and one SGLT2 inhibitor should be fine. So basically from all perspective, this combination looks excellent.
So you want to say that the first point of diagnosis, whether it is third decade or fourth decade, should go
yes.
for these two combinations.
Provocative, yes.
Yes. You are provocating
Yes.
the younger generations to write this one.
Yes.
Okay. So I will speak to you after a few years that what you are advocating.
Right. Okay.
But
So just
having
to
said that,
sir.
I continue prescribing metformin, I continue
Exactly.
prescribing gliclazide, I continue prescribing
I have followed your prescription. 60% of the prescriptions carry metformin.
Right. So let me just summarize two things. The first bit is we don't argue that glycemic control is important. Whatever combinations we are talking about, we will probably need all of the drugs to achieve good glycemic control. So let's not forget that glycemic control is not important. Of course, when it comes to the ancillary benefit of the drugs, we do understand that the newer drugs like SGLT2 inhibitors have benefits, GLP-1 have benefit, and the point that Sir was making about metformin, it's of course a controversy. The European Cardiology Society actually moved out metformin even before the Americans did, and essentially there are two sides of the story. We still don't know which side is true. Number one, we've got to remember that all of these CV outcome trials have been done on a background of metformin therapy and not without a metformin therapy. The only reason that the ADA-ESD combined guidelines stated that metformin might not be that good as first line is one meta-analysis in which they looked at all of these CV outcome data, and they looked at, in the CV outcome studies, there were some people who for some reason were not on metformin. Either they did not tolerate or otherwise, and they combined and they compared the results of those on the both on a background of metformin versus those not on a background of metformin, and that they found that the people who are not on metformin, they did slightly better. That's the reason why that ADA-ESD combined position statement has made this statement. But I think we'll watch the space, and taking Sir's cue in terms of combination drug, given a choice, first line, I will probably choose a triple drug rather than a dual drug. I will keep my good old metformin, I will keep my SGLT2, and I will keep my gliptin. Who will keep which one depends upon number one, the cost, and number two, the clinical evidence as well. Thank you so much.
Thank you so much. No more question after chairman's comment, no more question.
Right, okay. Thank you so much, sir.
Now, thank you very much, sir, for your excellent talk and discussions we had. Now, I'm going to invite Dr. Ved Prakash. He's a professor endocrinology in IGIMS. Over to you, Dr. Ved Prakash.
Thank you, respected chairpersons, and thank you, organizing committee, for this opportunity. So my topic is already most of the things are discussed by Dr. Ajay sir, such a brilliant lecture. And my topic is sitagliptin and overweight. Already most of the things are discussed in the previous lecture by sirs, chairpersons and the audience. So, coming to the complexities of type 2 diabetes management, there are various, besides glycemic control, we have to address hypoglycemia, weight management, we have to also address comorbidities, and drug adherence is also important. And day by day, the complexities of type 2 diabetes management increases, and this is the therapeutic pentad and pentuplex, in which we have to address not only glycemia, we have to address lipids. In lipids also there are 5 factors. We have to manage the psychological point of view of the patient, and in that also we have 5 points. We have to manage the weight of the patient, we have to manage the blood pressure of the patient. So the complexities of the type 2 diabetes management increases day by day, and it is very clear that one size does not fit all, and right treatment should be started in the right patient at the right time. So there are multiple options, there is no doubt, and we have to choose right one. Currently there are 12 classes of anti-diabetic drugs are available in the market, and recently one more class, imeglimin, is also added. So currently 13 classes of anti-diabetic drugs are available in the market, and we have to choose according to the patient's condition and the other comorbidities and other things. So more classes of drugs are available, more drugs. Every 1 year or 2 year, one more new drug is added into the every drug class, and various non-medical therapies are also available, combination therapies are available, multiple permutations and combinations are available. So but in spite of all these increasing the therapeutic armamentarium, the reality is that even in the developed countries in the current days, the long-term glycemic control is achieved only in 50 to 60% of the cases. So this is the basically basics of this incretin effect. So in this very famous experiment, the researcher found that when we give glucose by oral route and the same amount of glucose is given by intravenous route, the amount of insulin secreted when glucose is given by the oral route is more in comparison to the glucose given by the intravenous route, and this is known as the incretin effect. And the two main incretins, GIP and GLP-1, are discovered, and the mechanism of action of GLP-1 is that upon ingestion of food, GLP-1 is secreted from the L cells in the intestine, and this in turn stimulates glucose-dependent insulin secretion from the pancreatic beta cells. It also suppresses the glucagon secretion from the pancreatic alpha cells. It slows the gastric emptying, and it reduces the food intake. So these are the 4 major mechanisms of action of this GLP-1. But the problem is that the natural GLP-1 has very short half-life of 5 to 6 minutes, and it is very fastly degraded by the enzyme DPP-4. And if we block the DPP-4 enzyme by the DPP-4 inhibitor, then we increase the GLP-1 level 2 to 3 times by blocking DPP-4 enzymes. So efficacy of basically DPP-4 inhibitor is determined by the extent of plasma DPP-4 inhibited over 24 hours, and maximum glycemic benefit is achieved when DPP-4 activity is blocked by at least 90% over the full 24 hours. So how much DPP-4 stays uninhibited 24 hours after single highest approved dose of gliptin? And in this comparative study, we found that if we give vildagliptin in a single dose, the 71% of DPP-4 is uninhibited. With sitagliptin, whereas with sitagliptin, only 8.3% of DPP-4 is uninhibited. So sitagliptin, it is by seeing this data, it is very clear that the DPP-4 inhibition activity is we can achieve more than 90% DPP-4 inhibition by sitagliptin. So the selectivity profile besides DPP-4, there are also DPP isomers are available like DPP-8, DPP-9, fibroblast activating protein, and so we need a molecule which is more selectively inhibit DPP-4 and has little effect or no effect on DPP-8 or DPP-9. In that terms, the two most selective DPP-4 inhibitors are sitagliptin and linagliptin. So, comparing the pharmacokinetics of various gliptins, the sitagliptin is once in a day, should be used once in a day, once daily dose. Vildagliptin twice daily dose, sexagliptin, elogliptin and linagliptin once daily dose. So active metabolite is seen only with the sexagliptin, no other gliptins have active metabolite. Protein binding is high with linagliptin, that's why renal excretion is very less with linagliptin. And dose reduction with renal impairment is required with sitagliptin, vildagliptin, sexagliptin, and no dose modification is needed in terms in case of renal failure with linagliptin. So the sitagliptin, when used as a monotherapy, the HbA1c reduction in the tune of 0.7 to 8%, and in various studies it has been found that the HbA1c reduction with sitagliptin is slightly better in comparison to the lina, sexa and vildagliptin. So not only as a monotherapy, when sitagliptin is added either on the metformin or with sulfonylurea or with pioglitazone or with alpha glucosidase inhibitors like acarbose, there is further decrease in the HbA1c is seen with the sitagliptin. So this is the graphic representation of the same when sitagliptin is used as monotherapy or as an add-on therapy to the metformin or as add-on therapy to metformin and sulfonylurea. There is further decrease in the HbA1c achieved with the gliptins. The very important thing is that the drug adherence is very important in the management of diabetes, and with gliptins it is a very good class of molecule that has a very fewer side effects or rather little side effects, and the adherence is very good with all gliptins, there is no doubt. With metformin, side effects like GI side effects, with GLP-1 there are GI side effects, with SGLT2 genital infection, mycotic infection, UTI. But with gliptins, the side effects are very less and the adherence is very good. And not only these gliptins or sitagliptin has reduced the glycemia in the short term, there are various studies in which it has been seen that sitagliptin has the glycemic durability of 5 years, and even one study the glycemic durability is seen up to the 7 years of the duration. So sitagliptin, the glycemic durability is very good, 5 years up to 7 years. Now coming to the DPP-4 and comorbidities, cardiovascular disease, the DPP-4 class of drugs besides glycemia control, it has multiple pleiotropic beneficial effects also, that like it decreases the myocardial infarct size, it improves the endothelial function, it has anti-inflammatory property also, it decreases the atherosclerotic plaque volume, and it also improves the left ventricular function. And for the seeing one of the cardiovascular outcome trial with sitagliptin is the TCOS study, and TCOS study it has been very clearly shown that the 4-point MACE reduction, the sitagliptin is non-inferior to placebo in terms of the reduction in the 4-point MACE, and in terms of even in the hospitalization for heart failure, sitagliptin is non-inferior to the placebo. So there is no beneficial effect, but at the same time it has been proven that sitagliptin has no harmful effect on the cardiovascular system in terms of 4-point MACE or hospitalization of the heart failure. So TCOS study is the longest cardiovascular safety outcome study within the class. sitagliptin, I have already discussed this. Comparison of all DPP-4 cardiovascular outcome trials. There are various CVOT trials like Savartimi with the sexagliptin, examine with the elogliptin, TECOS with the sitagliptin, and in this cardiovascular outcome trials, in the Savartimi trial with sexagliptin, it has been found that there is increased hospitalization for heart failure seen with the sexagliptin. Whereas in the examine trial with elogliptin, it has been found that there is trend towards the increasing the hospitalization for heart failure, non-significant increase in the hospitalization for the heart failure. So, seeing these cardiovascular outcome trials, it is very clear that sitagliptin is a safer molecule. It has no harmful effect on the cardiovascular system. Now coming to the gliptins in CKD, all gliptins can be used in CKD. There is no doubt whether it is Sida, Vilda, Sexa or Lina. The only point which goes in favor of linagliptin is that there is no dose modification is required with linagliptin, whereas with Sita, Vilda and Sexa, we have to modify the dose according to the GFR. So with sitagliptin, in CKD 1 and 2, it can be used in the full dose of 100 mg per day. In CKD 3 stage, its dose should be reduced to the 50 mg, and when GFR falls between 15 to 29, below 30 ml per minute, the dose is the 25 mg per day. So, and sitagliptin can be used even up to the stage of the end stage renal disease. So, one of the when subgroup analysis of TECOS study was done, CKD was present in almost 23% of the participants in the TECOS study, and the treatment with sitagliptin was generally well tolerated with no meaningful differences in the safety outcome observed between those with CKD assigned to sitagliptin or placebo. So even in the subgroup analysis of TECOS, it is very well established that sitagliptin is safer even in the CKD patients. Coming to the hepatic impairment, sitagliptin is indicated in patients with hepatic impairment in mild to moderate hepatic impairment, but there is no data available in the severe hepatic impairment patients. Vildagliptin should be ideally avoided in the hepatic impairment patients. And linagliptin can be safely used into the mild to moderate degree of hepatic impairment, but there is no data available in the severe hepatic impairment. So besides these glycemic effects, there are various extraglycemic effects like sitagliptin significantly reduces the systolic and diastolic blood pressure. It has a favorable effect on the lipid profile. It decreases the triglyceride level and non-HDL cholesterol level significantly. Sitagliptin can reduce BMI and occurrence of hypoglycemia in the obese type 2 diabetic patients, but not in normal type 2 diabetic patients. And sitagliptin also has anti-inflammatory actions, and it reduces the level of the interleukin C, CRP, and other various anti-inflammatory markers, various inflammatory markers. So the side effect profile with sitagliptin is very acceptable, and there are no major adverse side effects related to the sitagliptin. In various studies it has been proven. So sitagliptin has advantage over the molecules in the DPP-4 segment. It is approved from the US FDA. CVOT, renal and hepatic safety data is available. Dosing is convenient. And the DPP-4 enzyme, it is highly DPP-4 selective inhibition achieved with the sitagliptin. So, as a whole, DPP-4 class of drugs are efficacious. It are all are safe and hassle-free usage and experience we observed with the use of the DPP-4 inhibitors. Thank you.
Thank you very much. Now, any question? Any question from the group?
ऑलरेडी डिस्कस करा पिछले क्लास में, पिछले
Thank you very much for an excellent audition. And now we are moving to a next session. Thank you so very much.
I'll request the first speaker as well, Dr. Ajay Kumar sir, to please come. नहीं सर, फिर से आपने कहा किया सर. I request the chairpersons also please come on the dais. Meanwhile, I request postgraduate students, those who have prepared for the poster, they can set up the things in the hall B. So first I request Dr. Ajay Kumar sir.
पोस्टर में तुम लोग कितने लोग हैं? सब लोग हैं ना? तो वहाँ पे असिस्ट कर देगा वो.
A big round of applause for Dr. Ajay Kumar. He finished well before time, but he faced a battery of questions and queries, and of course we all feel enlightened after his talk. Yeah. And now Dr. Ved Prakash sir. May I have a bouquet for the chairperson? And a bouquet for I will request the speakers to please honor the chairpersons with a bouquet.
नींद बना रहे हैं, दिल बना रहे हैं अभी.
Can we have a big round of applause? PG students, breakfast नहीं हुआ क्या? चलो, big round of applause. Thank you so much. So for the next session, may I request Dr. Ajay Sinha to chair the session. Professor Dr. Vinay Kumar sir, please chair the session. They will introduce the speakers for the next session.
Very good morning, you all. My regards to seniors and regards to chairpersons also. Thank you, Team RSSDI, for inviting me and giving me opportunity to part of this wonderful program. और खासकर शाम का program तो wonderful था. So hilarious, and you are giving me opportunity to have enjoyment with all kind of aura. Thank you very much. So to start this session, I am going to invite a well-known dermatologist of country seated at Kolkata, Dr. Sujay Bose.
Thank you, sir.
Sorry. He is a DM and he had published a lot of papers, a well-known figure. We know in the last 20 decades, huge investments have been done in dermatology. So before 2000, there were no such large investment. But after 2020, this century, last 20 years, huge investment have been done to find out the deeper understanding of pathophysiology of diabetes. And that led to many of the consumption which we are accepting and which many of the things which are going in the backseat. So one important marker of the diabetes management is HbA1c. So previously we were giving the emphasis to fasting and PP. Now is the turn of HbA1c and many other things, many other markers. So what is the situation of HbA1c? Should HbA1c, predict in every situation in the similar fashion or something else? So to settle this issue, may I invite Dr. Surya Ghosh sir, please give your oration. Over to you.
Thank you, sir, for that kind introduction. I have about 17 minutes to cover 70 slides. In terms of HbA1c, everybody would say, what's there new about HbA1c? So this talk I prepared for my DM residents because I found them looking at the graph of the HbA1c and then wondering how to make head and tail of it. And in your clinic also you will see when the patient comes with an HbA1c report, you look at the report and you then start writing. The patient says, "Aapne graph nahi dekhe, Doctor Sir." So graph mein dekhna kya hai? So that is what I will try and show in about 10 or 12 cases. The first bit is a little bit about a recap of what all we know and then interpretation of that graph that we actually flip over without even looking at. So we are all talking about measuring glycemia. So the first biological glucometers were perhaps the ants. So you had peed and the ants came to your urine, so you knew there was glucose in the urine, and that's how you diagnosed diabetes in the past. So as mentioned by the chairperson, it plays a key role in the management of diabetes, and we all now talk about all outcome data where HbA1c is a key measure of all our data. Now it all started with the DCCT study in 1993 for type 1 diabetes, and it was only in 1994 that ADA started recommending it as a target, and as late as 2010 that ADA said that this should be included even in the diagnostic criteria. So we know hemoglobin reacts spontaneously with glucose to form glycated derivatives in a non-enzymatic manner. And it's not just hemoglobin, it's probably every protein that we have in the body. And we tend to use certain terms very loosely. Glycation, glycosylation, all of these terms we use. Probably the term glycation or glycated should be used as an universal terminology. It's also called fast hemoglobin. Basically you are doing a chromatogram. Whichever part moves quicker than the rest, that is moving faster, that is fast hemoglobin, that is also what it is called. So when you are talking about HbA1, it is the total glycated hemoglobin, which has again A1A, A1B and A1C. We are actually concerned about only the A1C bit of things. So when the report comes, look whether it's a total glycated hemoglobin or whether it is a true HbA1c, where the glucose binds to the N-terminal valine of the hemoglobin B chain. So here you have hemoglobin, you have the total glycated hemoglobin, you have then A1, in that you have A1A, A1B and A1C. This is what we are actually interested in, which is about only 5% of the total. So a little bit about the chemistry. Here you have the hemoglobin chain, here you have the glucose. They bind together to form a labile HbA1c, which is, if you remember your class 12 chemistry days, is a shift based on what is called an aldamine. That then undergoes rearrangement to form something which is more stable, an amidoric product which is a ketoamine. This is stable, this is unstable. The reason I am talking about this is because if you have sudden changes in glucose levels, this amount of labile A1c will increase dramatically. And all of these tests that we do, if the level of labile A1c is above a certain cutoff, you cannot interpret the test result. You have to interpret it with a pinch of salt. So I'll skip some of the slides. I'll skip this as well. So we've talked about that 80% of hemoglobin A1 will be A1c. Sometimes you will find that urea might get attached to the hemoglobin as well to form what is called carbamylated hemoglobin. This is another problem that you will face when in patients with chronic renal failure. Depending upon what method you are using in estimation of HbA1c, this will also cause interference in your estimation of HbA1c. So we are all talking about that this is a measure of what's happened in the last 3 months with 50% of the weightage of what has happened in the last 1 month. So these are the various methods by which A1C reports are being done. Ideally, we should all be sticking to only HPLC method when we are talking about hemoglobin A1C estimation. Unfortunately or fortunately, people will get tests done from various places with various methodologies, and you have to be aware of the shortcomings of each of those methods. Now there might be some situations where HPLC will be erroneous, where you might be wanting to bank on something else depending on the clinical background of that individual. So the ion exchange column is one of them. The HPLC is what we are all talking about. You need a very small amount of blood. 5 microliter of blood is all that is needed. Why I am talking about the rest? Because sometimes the labs do not store the blood properly. So you are going to take a blood sample. Usually it will be an EDTA blood sample. Do not take a heparinized blood sample. You can even take a fluoride blood sample. And depending on how long you can store will depend on whether you are storing at minus or up to 4 degree or is it up to minus 70 or minus 80 degrees centigrade. Remember, one of the things that I have already told you that there is a labile complex that forms. So you've got to get rid of that labile shift base. So each of the machine has a particular method. For example, the D10 machine, you will have to incubate for 30 minutes separately before you can run the test. The Tosho's machine, it does it automatically. So, like I said, the analysis of the run time is very small, 3 to 5 minutes. But for example, the BioRat machine will take half an hour. And the coefficient of variability is very important because even a 3% variability is what is the international standards accept is going to give you a change of almost about 0.5% in A1C difference, remember. So the precision is very, very important. Immunoassays. This is a very common method that is reported. You will see particularly the Roche machine which does several other tests, in addition often does an immunoassay HbA1c. That does not detect the hemoglobin variance. Eastern part of India particularly, hemoglobin E disease and hemoglobin beta thalassemia and hemoglobin E beta thalassemia is very, very, very common in this part of our country. The boronate method is not affected by carbamylated hemoglobin. So, if somebody has got chronic renal failure, this will probably give you an edge over some of the other methods that we are using. Now, we all talk about that the HbA1c gives me an estimated average glucose reading, but that is all Western data. What happens? Because we are talking about glycation, right? It's an enzyme which does it, or in this case, it's a non-enzymatic glycation. So it will depend upon genetic variation as well, ethnic variation as well. Do we have the same kind of glycation as the Western population? We don't know. And there is now some studies to show that some people are fast glycators, some people are slow glycators. So what this study correlates and suggests might not definitely be correlated in every ethnic population is something that we also have to keep in mind. Now in 2007, everybody came to a consensus that you will no longer report HbA1c only as percentage. We all still stick to that percentage. That is what we are conversant with. But the IFCC, that is the International Federation of Chemical Chemistry, has said that you will have to have a dual reporting method. That is as A1c percentage as well as millimoles per moles. Now, do you know why this happened? Because and do you know on what basis we talk about HbA1c 6.5 or 6? So I talked about the DCCT study. It had 32 centers, and these 32 centers were doing the study in whatever methodology they were doing. So the study, the primary site, which had the highest number of patients, they said, we don't care. What would be your results had you done it in our method? So therefore you see all of the results says DCCT aligned. So that means, so X center might have done it with some other method and might have got a value of 8. That value, if repeated in that primary site, might have come as 7. So they will put a formula and back calculate it to this method. Now with advancement of science, it was found that this method that primary site used was rubbish. It was actually overestimating A1Cs. And over so many decades, we have got so many publications So if I now tell you what that DCCT value of 6.5 was actually 4.5, it will cause huge confusion. So they said, okay, we will have this dual method of reporting, but the millimoles per moles will be according to the new method, which will be the pure method of estimation of HbA1c. So all of that DCCT element, see, I told you, the IFCC method is actually DCCT minus 2.15 into 10 point something. It's a very complicated formula to remember, right? So this editorial I was fortunate to write for diabetic medicine, and we came up with this guide. So how do you convert the old value to the new value? So imagine somebody said his HbA1c is 7. Okay, so 7 minus 2 is 5. 2 minus 2, 7 minus 2 is 5, 5 minus 2 is 3. So put the digits together. So 7 corroborates with 53. So this is called the minus 2 law to convert the new method from the old method. So the sample storage that I have told you is, if you store at 4 degrees, you can store at 1 week. If it is minus 70 degrees, it can be stored up to a year and a half. So some of you wanting to do research might want to store up all the samples and do the tests in one go. Then you will have to store the sample at minus 70 and not in the standard refrigerator of the lab. So there are plenty of sources of error. So I have told you, if we said up to a CV of 3 is acceptable, even a CV of C gives you a A1C difference of 0.7. Just imagine, just because it is so precise, it is so small a value, there if you have even that 3% error, it will give a difference of say 6 versus 6.7 HbA1c. Big difference. Now, all of the various methods that are being used and touted, whether it is point of care, आपके clinic में आ जाएंगे, कर देंगे HbA1c. Now, all of you can go to the NGSP website. All of the HbA1c methods that you are talking about, you will find whether it is approved or whether it is not approved, or what is the limitation of that method. Maybe one machine does not detect hemoglobin E. Maybe one machine does not detect hemoglobin C. So like that. And this is from the NGSP website. You can go and figure out which machine is giving you what results. The commonest HPLC machine that is used in our country is Biorad D10. So you can get from the NGSP website. So these are, say for example, some of the point of care machines that we are using, and we are thinking that we are doing a great job, right? Cross-check whether that machine is good enough for clinical practice, because most of them are not. So I hope I'll be given a little time, because I'm going to discuss a few cases from now on. So a few clinical cases, look at this. I'm sorry you might not be able to read, but you will find the graph comes like this, right? And it has, here it says peak, here it says HbA1, A1C and things like that. This HbA1c, I'll just read it out. It reads as 20.1%. HbA1c का report आया है 20.1%. So you will have to remember that every machine has a highest ability to read something. That is above which the linearity is lost. For example, you have a weighing machine. You are putting the weight that weighs up to say 10 kilograms. So can you say something's weight is 11 kilograms? So the Biorad machine, for example, if you look at HbA1c, the highest that it can go up is up to 18.5%. So definitely that report is wrong. So you got to know कि मेरा machine का range क्या है, up to what can I measure. The second you can see perhaps little clearer. See, when you read here, there is something written as peak, there is something written as A1A, A1B, F which is fetal hemoglobin, LA1C is labile A1C. Now you know what labile A1C is. You know there is something called CHB, which is the carboxylated hemoglobin, and then you have the HbA1c. There is a P3 window which includes the other components of the hemoglobin, A0, and then here you see there is something different here. Here it says in addition it has detected something called an S peak, and that accounts for 38%. Now you expect in this graph that the A1C will be somewhere around 70, 80, 90%. That is what it should give, and the A1C is only 7.4%, and it says that the percentage is 7.4. But the moment you have a variant window, it tells you that there is a hemoglobinopathy. And here it says it's an S window, implying this has got sickle cell anemia. So this 7.4% HbA1c you cannot interpret. So forget about A1C, doing A1C in this particular patient. Similarly, look at this another patient. Here again, you will find A1C has come as 6.8, but what has happened to, there is another variant window, which has come as 40.8%. Now you will know that this hemoglobin A1C machines, they have two modes, A mode and the A2 mode. The thalassemia screening is done by the same machine in the other mode. Here, they have not told you what is the variant window. You might want to know what kind of hemoglobinopathy this person has. You can then move to what will be, this is an A2 mode and this is an A1. So this, for example, you see, I don't know whether you can read, the A1C is 0. HbA1c cannot be 0, right? There's something wrong in it. So you have run the A2 mode. So the hemoglobin which knocks out the standard A1C in our population is hemoglobin E. So even if you had not done this, you are almost certain that this is got hemoglobin E disease. So this is homozygous hemoglobin E disease. That is why HbA1c has come as 0, and here you can see that there is a big peak at the level of E. If it was heterozygous, you would still have had a variant window. For example, here you can see 85.9. You would have had a variant window, maybe 40, 30, something like that. And if you had run the A2 mode, you would have found that there is interference. Moving on to the next patient. So here again, you can see the fetal hemoglobin. Can you see here, fetal hemoglobin? I'm sorry, this is F, this is 15.5. I'm sorry for the poor quality. Now normally, if the fetal hemoglobin content of an individual is more than 10%, you cannot interpret HbA1c. So I'll just show you something, that these are the things that you have to keep in mind when you are interpreting HbA1c on an HPLC. Anybody having a bilirubin more than 20, there will be false interference in the A1c. Very high triglycerides, above 5,000, will have a problem. If the fetal hemoglobin is above 10%, there will be a problem. If the labile hemoglobin is more than 4%, there will be a problem. If the carboxylated hemoglobin is more than 3.5%, there will be a problem. So we've got to think of looking at that graph looking just at the report and saying this is 7%, this is 6.8%. Start looking at the graph to see what did the biochemist actually miss out. Or if the biochemist has given you a value of 0% HbA1c, don't scream at him. You know there's something wrong in the HbA1c. So this is again another individual. The reason why I'm saying is, don't interpret results on the basis of one graph or one report. You have to look at the patient as well, which the biochemist or the lab person does not have the opportunity. Here this individual has got a very low hemoglobin, and there a hemoglobin has come, A1c has come as 2.7%. What has happened in this patient is, this patient had a blood loss, and then somebody transfused blood, and the hemoglobin has come up to around 9%. But glycosylated hemoglobin to nahi hai. That is the reason, because you have got a false report like this. So you've got to think of what can be the causes of inappropriately low A1c, what would be the causes of inappropriately high A1c, and variable effects. So these are the certain disorders, and these are the certain drugs which can cause interference of the HbA1c. Now look at this. Actually, I traced this family back to Kerala. HbA1c of 54.2%. So you will say linearity chala gaya, something like that. No, this is hemoglobin hope disease. This is again not very uncommon in southern part of India. So this entire family I traced, and we've published this as well. This is hemoglobin hope disease. So again, similarly, here you can see the variant window, you can see is very high, 53% variant window, and we've done an A2 mode, and this is hemoglobin D, Iran, which is again not uncommon in India. Again, here you see we've actually gone and done the A1C with HPLC. We know that this is not going to give us a wrong report, so we've done an immunoturbidometric method where there would be less interference and got a better result. And this individual that I was showing you, we actually did an A2 method, and we found that this was having an alpha thalassemia. We've gone and done the genetics to prove that this is alpha thalassemia which was causing the interference. Again, if you look at this particular individual, you will see that the labile and the carbamylated hemoglobin is 26.1%. So I've already told you, if the labile is more than 4% or the carbamylated is more than 3.5%, you cannot interpret. This is an individual who's got chronic renal failure, where the carbamylated hemoglobin A1C was very high, which has therefore led to abnormal interpretation of A1C. Sir, 2 minutes. This again is a persistence of fetal hemoglobin. You can see I told you it has to be less than 10%, it is 25%. Finally, look at this individual who has got admitted for hysterectomy. A1C is 10.6%, whereas the estimate, and which would correspond to an estimated average glucose of 191. Fructosamine is also high, but when we looked at the CBG chart, it is not that bad. So remember that even iron deficiency anemia will cause excess of HbA1c, because the body will try to keep the RBC in your circulation for a longer period of time. It will not destroy it at 120 days. So it is going to get exposed to the glucose for an even longer period of time. So the amount of glycosylation of that prolonged lifespan RBC is going to be even longer, and the difference can be up to 1%. Similarly, there are hypothyroidism that will reduce turnover of the red blood cell, will give you falsely higher A1C of up to 0.4%. So I'll stop there by concluding that communication across disciplines is important. We tend to send the sample to the lab, and then the lab person has got no idea except the blood sample. Background history pata nahi hai. Unexplained report does not necessarily mean wrong report. We have to introspect. It's okay to say that you don't know why it has happened, rather than say it's wrong. And in such situation, go for an SMBG, go for an AGP. And we still understand that in several of the reports that I did not show you here, we could not still interpret and know the difference, why the clinical presentation and the A1C was different. Thank you so much. Sorry, I overrushed.
So what we have learned that yes, besides many metrics like fasting, PP, time in range, HbA1c, etc., HbA1c is one of the most important marker of type 2 diabetes mellitus management. And Dr. Sujay Ghosh has highlighted all those areas where we have some abnormal results, and what he has given at the end, that we have to look the patient. So only HbA1c at some occasions may not give you the correct result. So if you have any doubt, see the patient background, what Dr. Sujay Ghosh has pointed with this talk. So thank you, sir, for your wonderful presentation. And as I have told you earlier, that last 20 years, good for diabetologists, a lot of investments have been done by the pharmaceuticals, thanks to pharmacy, but that has resulted into something good, but something more complex. So we have to look for the benefit of the patient. So house is open for discussion. Thank you once again, sir.
Thank you, Dr. Sujay Ghosh. Excellent presentation with modern modification and current deliberations. I have only one thing to say, that on the forefront, on the one picture is shown, you should not be satisfied with that. There are many more pictures behind the screen also. We have to keep our mind and heart open to find all those facts and figures to point and think which is going to happen. That is the only thing. Nice, sir. Thank you very much. Any question?
What is your experience about the accuracy of point of care HbA1c?
Right. So if you look at the NGSP website, there is mention of at least about 50 to 60 point of care machines that are going around in circles, which had put in their applications for approval. There is only 3 machines which the NGSP website actually approves for point of care, and none of those 3 are actually available in India.
Sir, one thing more. Sir, what is GHB and how it is different from the HbA1c?
Right. So if you're looking at GHB overall is glycosylated hemoglobin. So if I told you the total glycosylated hemoglobin or glycated hemoglobin is HbA1c, A1A, A1B and A1C. When you're talking about glycosylated hemoglobin without making any other comments in common parlance, you should be actually only measuring HbA1c and not HbA1b and HbA1a. You should forget about those two. But there will still be some machines which are actually giving you HbA1, which includes A1a, A1b and A1c.
How much difference between, usually difference between GHB
So
and HbA1c?
about 80% of GHB is A1c on an average.
There are other methods to measure the long-term glycemia like the fructosamine and 1,5 and hydroxystrol 1,5 kg, and that is suitable in some of the circumstances like gestational diabetes mellitus. There are indexes which comprises the HbA1c, 1,5 and hydroxystrol and the fructosamine. There is a problem once you are assessing a patient who is having shorter duration of diabetes where beta cell reserve is more, and patient who is having longer duration of diabetes where the beta cell function are not that much. In course of time the beta cell functions are lost. We all know that the visit-to-visit variability of the blood glucose and the HbA1c depends upon the beta cell function. So what is your experience regarding the HbA1c variability, provided it has been done with the standard method, no hemoglobinopathy is there? The interpretation of that delta Hb is we should rely more, or we should rely on these shorter fluctuation like 1,5 and hydroxystrol and fructosamine.
Right. So first of all, whether we are talking about fructosamine or anhydroglucitol, it predicts glucose control for a much shorter period of time. Now, I am unable to get 4 A1Cs from a patient annually. I don't know how many of you can get it. So if I am not able to get 4 A1Cs a year, how many fructosamine results will I have to get annually? Number one. Number two, in terms of the cost. And number three, information is important if you are acting upon it, right? So if you have enough information to make the changes even on a 3-monthly basis, which we are failing like Sir showed in the ICMR INDAB study, then what's the point in doing something even more frequently, except in few situations? For example, if you're talking about pregnancy, you want to intensify? Yes. But in the common day-to-day clinical practice, I think if we are able to have even 2 HbA1Cs a year, I am happy with my patients.
I have a very simple question. We do a CGM using freestyle liver flow, and they give you an HbA1c percentage.
It gives you an estimated average glucose, which they think will corroborate with your A1C.
Exactly. So how do you interpret that?
Very difficult, because you are doing the CGM for 15 days or 14 days, and then they have an average value. They presume that had it continued in this manner for the next 3 months, this is what the A1C would have been. But you know, what a patient does in 15 days is not necessarily what he does for the next 2.5 months.
I don't have any question, I just have one comment, that we need more than 1,000 professors like Dr. Sujay Ghosh.
Not calibrated or not been recognized in India, then how can we interpret it?
It's difficult, that is what I'm trying to say. And every time I see a patient, not only do I write down the value of whatever I found, next to it I try to write down on what platform it was done, what machine. It's important actually. And again, maybe I will say something controversial, that is, if I find somebody's fasting and postprandial readings are bad, I don't go for an HbA1c. Because if the individual value is high, what am I going to gain out of doing a cumulative test? I only go for it only when I see, okay, more or less fasting PP ठीक चल रहा है, बाकी का टाइम ठीक था तो, पिछले 3 महीना ठीक था तो, इसलिए you can tailor it accordingly. Because not it, see, it costs money. It is expensive in our country, and then you still don't know whether the money that you spent is standardized test or not.
Very right, sir. Just I want to, in your support, I want to give one example. In one patient, I got that HbA1c was just 5.8, and the patient fasting blood sugar was 88, and the patient had presented with hypoglycemia. The patient had presented that he was having some dizziness feeling, he was working in hospital, so she told sister to estimate blood sugar, and it was only 43. So he was surprised how it happened. We thought that maybe he will have a CKD, so he was not having CKD, everything was fine. Then I got that he might be having reactive hypoglycemia, secondary to hyperglycemia. So in that situation, I had told him to have 1 hour and 2 hour PP, and then 4 hour PP. So 4 hour PP was, again, it was very low, and 2 hour PP was 220. So it was reactive hypoglycemia, it was very atypical presentation. And again, some controversy was there whether we should keep him on voglibos or whether on what metformin, because voglibos will prevent from postprandial hypoglycemia, but the patient is doing well on metformin.
So the more important point that you make is HbA1c is an average. So if you have a blood glucose value of 200 and another of 50, you might erroneously start thinking that the average is good. So obviously you have to think of the clinical scenario of the patient, the background of the patient. Is the patient having swings of glucose, as a result of which the hypoglycemia is pulling down the values of the HbA1c? Point taken.
Maybe he said I was 20, only 2 hours was 20, 220.
I have a last question. Recently there were controversy even by the American College of Physicians that relaxation should be done. It should be done in between HbA1c 7 to 8. How do you comment about it? Because previously we are keeping the HbA1c below 6.5 or in between 6.5 to 7.
But what I'll put it in a different manner. I remember one of the debates. This was after the Accord advanced VADT study. People started saying, please do not lower HbA1c below 7.5 or 7 or something like that. Don't target 6 or 6.5 as was in Accord. So I asked the audience, in the audience, a lot of you will not have diabetes, right? And you have an HbA1c of say 5.8. So should you be increasing your A1Cs to survive? So the basic concept of target depends upon how much can you lower safely. Whatever you can lower safely until whatever level, you should be trying that as close to near normal. So we are saying A1C 5.7 is normal, but when we are talking about targets, we are saying 6.5 is your target, 7.5 is your target, 8.5 is your target, depending on the background of the patient. So for example, somebody is elderly, multiple comorbidities, there is no way you are going to be able to safely reduce it to say 6.5. But I'll leave you with more questions in the sense, you look at the semaglutide studies and you look at the new twin cretins and the triple antagonist drugs. They are reducing HbA1c up to 2.4%, 2.5%. The day will not be long when ADA is going to change the guideline and is going to say, not 6.5, but bring it down to 5.7 if you can do it safely.
Regarding the reversal of diabetes, Canadian guidelines have put the target of HbA1c 6. So if you want a diabetes reversal and you can safely reduce the HbA1c to 6 without causing hypoglycemia, these patients are good potential patients for reversal.
Sir, 2 comments. Again, the target is whatever people are deciding upon. That can be a controversy, but again I said it depends upon the safety. And I have a big issue about diabetes reversal and remission. It's temporary remission and not reversal. Let us not talk about, because it's a very fad word. It's going on, and the lay press as well as industry. You go to internet, you go to YouTube. The first advertisement that you will find is of digital twinning and diabetes reversal.
At least 6 is safe.
Whatever is safe. Whatever is safe.
At least 6 is not done.
What is safe in the message?
Reversal is absolutely none. There is always
So message is given by Dr. Sujay Ghosh that yes, which is safe you can keep for the older patient 7 to 8, younger patient no comorbidity less than 7 is a good. So thank you sir. I think they were. Thank you for enlightening us, making us more empowered in the field of diabetic patterns. Thank you.
Now I request Dr. D.P. Singh, ex-professor of respiratory medicine. Medical College, Bhagalpur, to kindly deliver his lecture of TB in diabetes mellitus. Dr. DB Singh, please.
And you know well that DB Singh needs no introduction. He is as popular at Bhagalpur, as popular in Patna, as popular as in Delhi. So he is omnipresent. So this is his description. Omnipopular, whatever you can say. And he is a present, in Patna meeting, he is managing from Bhagalpur, and you will find more than 100 delegates will be present in the meeting of Dr. DB Singh, which is the credential of Professor Dr. DB Singh. Over to Dr. DB Singh for a topic. When the world has kept the TB to eliminate it by 2030. But Dr. DB Singh and India has taken the oath that we will eliminate TB by the year 2025. So how he will deliberate it? Thank you, sir.
Thank you, chairpersons, for kind words. And the topic today is diabetes and TB. Double. And let us see, this is the tandem. You know, tandem is a bicycle having two seats. And the front seat may be diabetes, second seat may be TB, or first seat may be diabetes acquired, and the second seat may be TB. So, vice versa. And both helping each other. And how they help, how they create problems, what will be the problem in the diagnosis, what will be the problem in the treatment, and these all things we shall try to discuss in next few minutes. So it's a tandem, tuberculosis and diabetes. Historically, it is a tubercular diabetic. TB is a shadow of DM. It's long recognized, but appreciation was taken very long time. Even in Shushrut, this emphasis was there. Even the Avicina in 1980, they said yes, there are documentation that there is association are there. There are autopsy reports that says 50% of diabetics and they have got the autopsy of TB. So the diabetes can increase the risk of tuberculosis treatment. So it is not the double trouble, it will be triple trouble. So this is very important, and Indian state of Kerala says 44% of TB patients have got diabetes. Tamil Nadu says 25% of TB has got diabetes. There's a variation, maybe few percent, 244%. That is the enormous association of TB and diabetes. And prior to insulin era, diagnosis of TB means death sentence. Diagnosis of DM was death sentence. Leading cause of death was TB. After this insulin era, yes, the patient has got this control, and that this association still is there. In 2015, there was collaborative study for framework that we should see this, how they help each other and how to control it. And this is a global burden, syndemic. 336 million people living with DM. And 10.6 million people living still, even in Bhagalpur we can say, per 1 lakh of population, still we have got 188 patients of tuberculosis. It will be just a miracle. There is that we can eradicate tuberculosis, we can maybe eradicate TB by just after 2 years. It will be just a dream. But still we see. And there's 10.6 million people TB, and most of this, whether it is diabetes, whether it is TB, 80% of these population are there in the low and medium group country like India. As yet, and the death is still, if it is diabetes, 4 million, still 12 lakhs people die annually in diabetes, tuberculosis also. And this is the intersecting of these epidemics. So how this is twin? If a patient has got tuberculosis, every physician will diagnose, and he can treat by the 6-month treatment of anti-tuberculous drugs. But if it is associated with DM, it becomes uncontrollable. And there are problems here. And the issue of why it is uncontrollable, hyperglycemia, you know the famous growth, increased availability of glycerol and nitrogenous substances, that will also increase the growth of the tuberculosis, and the diabetes itself will lower the immunity of the Th1 immunity, and that will favor the growth of tuberculosis in diabetic patients. abnormal chemotaxis will be there, peripheral monocytes have been impaired, poor blast formation, defective C3, defective Th1 immunity, and if you are able to control the incidence of HIV at present, but still diabetes you are not able to control, it is showing high. And these two factors are the risk factors majority of the patients of tuberculosis. And this is the impact of diabetes on tuberculosis infection. If a patient has got exposure of tuberculosis, if it is immunopotent, no problem of tuberculosis, 90% will go in the latent stage. Only 10% will have the activity. And latent stage, that also has got the annual risk of activation. 10% only. Lifetime risk of activation is there. But in association of diabetic mellitus, sir, 90% of patients after exposure can mainly go in the active state. So infections to active disease, 90% if there is association, if there is tandem of this diabetes TB association. And see this, if a patient has got mycobacterial tuberculosis infection, normally it goes to latent stage. It goes in the active form 10%, it is controllable. There is no chances of reoccurrence. There is no drug-to-drug interaction. But if it is associated with diabetic mellitus, it is immunocompromised, then the four things can happen. That diabetes is uncontrollable, TB is uncontrollable, chances of reoccurrence is there, long treatment you may require, you may have to change the drugs in that, drug-drug interaction is also there. So these are the four things that creates problem in treating the disease. Again, there are, in the mycobacterial tuberculosis infection, normally there is good phagocytosis, good cytokines, good Th1 cells, good interleukins, good TNF-alpha, and there is mycobacterial death. But if all these mediators are not active, again, it will increase the tuberculosis infection. And these are all sorts of immunity mediators that will help each other. So my dear friends, what is this clinical presentation, how it differs? If you see the age, this combination has been seen more common with the age, because diabetes will go in the T2 diabetes more common, and gender, male is said to be the more having this infection, TB, DM combination. And in the clinically, we have seen that whenever it is associated with diabetic mellitus, this extrapulmonary TB is less common as compared to the pulmonary TB. So pulmonary TB is very, very common if there is association of the TB in contrast to HIV infection, where the extrapulmonary is more than 50% into this HIV TB combination. In diabetes, it is more common. A review by Stevenson said TB increases the risk up to the 7 to 7.8%. Another says 3%. This one review is said 1.9 to 35%. Again, American study also says the MDR resistance is more common if there is association of TB with diabetic mellitus. TB is also common in the type 1 diabetes, but the large volume of T2 diabetes, that is creating many problems. Whether the TB is a risk factor of diabetes? Yes, it is said the bidirectional relationship between diabetes and TB has been long recognized, because TB can lead to impaired glucose tolerance and there is new onset of diabetes. In one of the study, it was seen that 10.4% has got the impaired glucose tolerance and 8.6% cohort has got diabetes. After, no past history of diabetes. After the initiation of infection and the patient has got the activation of this diabetic mellitus. So, what is the effect of diabetic mellitus on pulmonary tuberculosis? More extensive exudation, more caseation, more hemoptysis, more pleural effusion, and the predilection is the hilar and basal region. So if anybody having this lower lobe tuberculosis, think about that diabetes is there or not. You have to screen in any patient if atypical site of tuberculosis is there. Always, any case of tuberculosis must be screened for diabetes mellitus. Diabetes may also be a risk for hepatic toxicity. So there will be more hepatic toxicity with the anti-tuberculous drugs. There is delay in the sputum culture conversion. There is increased double risk of death. So double trouble, triple trouble, but the double risk of death is also there in this condition. Recurrence is there, ERTB is also there. So what is the radiographical changes? I have told you that lower lobe involvement with cavitation, that should be the indication you must search for the diabetes mellitus. And these are the typical site, upper lobe, and the atypical site in the next X-ray, atypical sites in the second X-ray. So what we should do? Every clinician must do the screening of TM in tuberculosis. If you have got a diagnosis of TM, I have told you the data from Bhagalpur, this eastern Bihar, if you compare the western, they are more aware, doctors are there. They are not doing the, in cases of TB, not screening for diabetes, not screening for HIV. So that should be there. If any patient, if you have forgotten in the first stage, you always measure the blood sugar in every case of diabetes mellitus. So all patients of TB must be screened for DM as we do for HIV. Fasting blood sugar more than 126, impaired glucose tolerance 110 by 122. Patients with more than 200 should be diagnosed as diabetes. That's everybody knows it, all we are experts. So random blood sugar between 100 and 200 is suggestive of retesting. Always test it in the next visit, and confirmatory may be the oral glucose tolerance test. A study from South India compared the performance of, just now Sujay Ghosh give the very elaborate talk about this HbA1c. So performance of HbA1c with the fasting plasma glucose. It has been seen that the HbA1c is a better diagnostic tool for the identification of newly diagnosed DM among patients with disease. So HbA1c more than 7 has been associated with 3 times increased risk of active tuberculosis than less than 7. So my dear friends, diagnosis of TB is a bidirectional. So any patient, we are all diabetic specialists of diabetes, diabetologists are there in this hall. All diabetologists are asked, requested to screen for tuberculosis. Any slightest symptoms patient has got, whether it is cough, whether it is fever, because what we teach, that anybody having cough more than 15 days, then you diagnose. So even if the cough is there, even for less than 2 weeks, think about it. Because this is the infections that can create problem. So cough, any duration, unexplained weight loss, because the diabetes has got weight loss, and the TB has got also weight loss. So you have to think about that. If there is unusual weight loss, you think about that, whether there is any association of tuberculosis or not. Hemoptysis and other nitrates are also there. But this fasting blood sugar, this random blood sugar more than 200, HbA1c more than 6.5, and now every district has got CBNet. Every district. If here we have got 2 CBNets here, in every district has got. So dear friends, any dot, even if any duration of cough, please send the sputum for CBNet. And that will not only diagnose the effervescent sensitive TB, but also give you an idea whether it is a case of MDR, whether there is an effervescent register. So within 90 minutes, if a diagnosis can be made, why there is inertia on the part of physicians not to send sputum sample, not to have this suspicion of tuberculosis in large number of patients of diabetes that you treat. So bidirectional screening is very much important. How to manage this? And we have got a very brilliant lecture from Dr. Ajay Kumar, many of the diabetologists here. But despite suggestion that diabetes may lead to more severe disease, more death, more relapses, dosage, regimen and duration of anti-tuberculous drug among those with or without TB. Any repercussion sensitive, we have got this 2 months regimen of intensive phase 2 HRZD and continuation phase of 4 HRT. And you know that every patient we add the pyridoxine, and diabetic patient has got more common peripheral neuropathy. But Drug and drug interaction is very, very common. Anand Shankar will later on point out what is the reality, what is the clinical effects about this drug-drug interaction of anti-tuberculous drug and the anti-diabetic drugs. Rifampicin, you know, that is the hero of all the anti-tuberculous drugs, among the cocktail of anti-tuberculous. But it's a very important drug. But it has got large number of interaction with the many other drugs. Similarly, we see this rifampicin can reduce the plasma level of sulfonylurea. That is the common prescription glimepiride, biguanides also. Then there was leading the hyperglycemia among the non-diabetic patients. So even the isoniazid antagonizes the action of sulfonylurea. So that can also make the glycemia worsen. But in some situation, isoniazid can increase this inducing effect of rifampicin, outweigh the inhibitory effect of this. So there is overall the rifampicin is very potent inducer, giving rise to hyperglycemia. This may worsen treatment outcome in TB management. DP4 is said to cause immune paralysis because now today sulfonylurea, this SGLT2 inhibitor, DP4, these are the drugs that we talk about in treatment, and this also said to cause immune paralysis and possibly worsen. Possibly I say because there is no clear-cut guideline in that. Worsen treatment outcome in TB management. Similarly, thiazolidinedione is also having the lower level by rifampicin inducing effects. So in a cross-sectional study conducted in South India, significant higher proportion of patients with DM demonstrated resistance to rifampicin, and as compared to patients without diabetes. A Turkish study reported the plasma INH and rifampicin concentration in TB patients with diabetes more than this 50% lower than those observed in TB patients without diabetes. A recent study from India said TB patients with DM had got lower concentration of INH and pyrazinamide. Again, you know, pyrazinamide is a wonderful drug in TB treatment, and those without this DM. So my dear friends, routine monitoring of therapeutic drug response and fortification of TB regimen. If there is delay in response, you think about whether there is optimal dose of the anti-tuberculous drugs or not. So can you increase the dose of the drugs, or can you extend the treatment duration just in contrast to the 6 months treatment? So glycemic control in TB DM. Accepted target for glucose control in diabetic is less than 7. And as recommended by American Diabetic Association, although American College of Physicians recently recommended the HbA1c level 7 to 8. Next question is how to have the optimal glycemic control. First, we address the choice of glucose lowering agent, and we have got metformin. Just now you have heard from Dr. Ajay Kumar that metformin is out of the first line. Here in anti-tuberculous drug treatment with diabetes, we say metformin is the first choice of glucose lowering recommendation in type 2 diabetic mellitus. There is no reason that this should be different from patients with active TB disease, because advantage of metformin is extensive experience with this drug, extremely low risk of hypoglycemia, it's effective, it's low cost, it's beneficial also on the cardiovascular disease, and there is lack of clinically relevant interaction with rifampicin and potential benefit on TB, and interaction, you know, that is very, very common. Just now one of the reports says that metformin may be an adjunct anti-tuberculous therapy. And it has been seen that the metformin can control the growth of drug-resistant tuberculosis. So metformin should be one of the drugs in controlling the tuberculosis. But what is this role of insulin? Management of diabetes in patients with tuberculosis, the insulin has got a very great role to play, because it is the most preferred treatment in patients with severe TB disease with anabolic actions. In addition, practical advantage of reducing the pill burden is also there. As recommended by RSSDI, insulin must be given in the newly diagnosed DM patients. If HbA1c is more than 9, If fasting blood glucose is more than 250, if the patient has got ketone body, if the symptoms of hyperosmolar coma is there, and for those is a catabolic state. In patients already in OAD, insulin may be added as an ongoing therapy. Routine monitoring of glycemia and adoption of lifestyle modification should be there. So MDR patients, in patients with DM, delays in microbacterial TB clearance is there in the, and maybe the MDR incidence is also increased 2 to 9-fold in cases of diabetic mellitus. And these are the three regimens that we use if the patient has got MDR tuberculosis. If there is H resistance is there, we have got 4 drug regimen for 6 months. If the patient has got rifampicin resistance, H is sensitive, this MDR TB is there, shorter bedaquiline regimen is there, this 9 months to 11 months. But today nobody wants injection. Those patients who have got the MDR resistant TB and the first line drugs, we can go to the all oral regimen for the 18 months treatment containing this bedaquiline with the cycloserine, levofloxacin, linezolid and scopolamine. So this recommended lifestyle modification will always be there in both the disease combination, apart from giving the B6, B12, vitamin and other things. Stoppage of tobacco also. As the patient of diabetes has got the this cardiovascular comorbidity, and so addition of antiplatelet, antihypertensive and lipid lowering drugs should also be there in the patient of this. What is the RSSI clinical practice recommendation for diagnosis, prevention and control of diabetic mellitus? Just nutshell, we can say improved coordination between government initiated NTEP program and this diabetic program should be built in strategy to lower the DM burden. Increasing the awareness of DM and TB coexistence among the patients and the doctors. Propagating importance of self-assessment of TB symptoms among the patient. Patient should report to the doctor, yes, I have got this symptom. Implementation of infection control measures in DM clinics. All you have got diabetes clinic, where the infections can propagate to the others. You must have the improved ventilation in your clinic, must have the prevention of crowding in your clinic, separate waiting area for TB suspected patients should be there. DM treatment as a TB center should avoid contact of sputum positive patients with vulnerable TB. So my dear friends, to conclude, there is unholy alliance between TB and diabetes. Both can impact each other. There should be routine screening of DM in all TB patients, and all DM patients have got slightest suspicion should be have the exclusion of tuberculosis. With regard to TB treatment, there are many challenges in tackling this TB-DB combination. TB treatment has been intensified and special attention must be paid to the drug-resistant TB because that is a time bomb for us. Strategies for prevention of TB must be continuously emphasized, and TB prevention therapy in DM and LTBI should be explored, but it is not in our control program. Thank you very much.
What we have learned.
Sound up here. What we have learned, what Dr. Professor D.B. Singh has told, there is a cross connection between diabetes and tuberculosis, and both are very common disease. So if the person has got tuberculosis, he should be ruled out for diabetes. And if the person has diabetes and there is a symptom of cough, weight loss, any other thing for more than 14 days, one should rule out the tuberculosis. And both are very very common, so we have to keep in our mind. And he has suggested all those formulas. When two are present, what we have to do: hit hard, hit fast. And we have to apply all those newer tests, which is widely available in all the towns of the country. So this is the fact what we have learned. Thank you, sir, for enlightening us. And you have also talked about the public health measures, what we have to do, what we have to suggest as a clinician. So how is your for discussion? Any question or comment?
Very nice discussion, sir. Indeed. You are always versatile with your speech. And my question to the House and you is, do you think that tuberculosis will be eradicated in 2025? Because only 7 years have left. And you see the burden.
2 years left, sir. And I have told you that this is a dream. If it comes true, we shall be the happiest people. In this house, everybody will be happy that India having the 25% of world burden of tuberculosis, it becomes cured. Still we have, Dr. Rajkumar, still we shall have the 40% of latent tuberculosis that is still not being cared by the government.
So one thing I will add, that
I will go with
COVID has proved that the vaccination in the world is possible. So we are working on that also, that the tuberculosis in near future, you may see a vaccine which has to be inoculated to the people of the masses. Just like just like COVID. And we did it. We have done this and we can do it. That is what I want to say.
So what he has asked you, sir, I have also continued all those questions. You have promised as a professor and as an Indian citizen or Indian clinician that we will eradicate by 2025. So what is your data showing? Whether the tuberculosis is going down? Because what is my perception that with the fight from mycobacteria, it has remained victorious. What I know from my period. So whether the tuberculosis prevalence or incidence is going down, and once you are taking the dream, it is a dream, and Dr. Rajkumar Chaudhary has suggested that vaccination could help to bring down the prevalence and incidence of tuberculosis. So how do you comment? And if you say dream, what does it mean? It will mean that we will not able to control even after 2050 or 60. What is your view?
First of all, what is the annual decline of tuberculosis? I say initially when we started this, there was 1 to 2% decline in that. With the intensive treatment, we have up to 3 and 4% decline, annual decline of the tuberculosis annually. But lo and behold, this COVID-19 has come. COVID-19 has increased the rate of incidence, and we are back to that increase in the tuberculosis infection. So in 2023, we have got an increased incidence of this, and we have to tackle, we shall go back to 10 years back again, that the incidence has jumped down to 2 to 3% more. So annual decline has decreased. So from 2023, we shall have to control that COVID interaction, number one. Number one, initially when the program maker, we thought that in 2017 we shall have a vaccine. Because you know the BCG vaccine is just 100 years old. And still we are wishing that patient will get this vaccination at the birth, and the patient will have some immunity, not the biliary tuberculosis, not the tuberculous meningitis. But still the progress is there. We don't know that within 2 to 3 years we shall have the vaccine. But if vaccine comes, what will be the efficacy of that? We shall have to see that. But still we are hoping research are going on, and we may have the vaccine. But the effect of the vaccine, we have to see about the population, number 2. Number 3, that this is the promise pledge we have to take. Every year on 24th March, we take the pledge that yes, this year also, we took the pledge that yes, we can pledge that we shall end TB. So each one of you, each one related to you, have to take the pledge that please sir, diagnosis of tuberculosis, if the patient has, it takes 2 months to diagnose. 2 months. They are loitering in this Jhola Chhap doctors, and then coming to the right area where you can go for the sputum for CBNet, and you can diagnose it. If it takes too much time, how it will be spread? How much there is control infection program in our hospital. You see, lot many times you tweak the decision in the OPD, this TB patient should be the guest of us. They should be given priority. They should be screened off, red stamp should be there. They should go fast. They should be taken up earlier. Even the treatment, this long queue are there taking the drugs. They should not mix with the population. So there are a lot of things we have to do to have the dream come true. Rajkumar.
And isoniazid is one drug which blocks the vitamin D and vitamin D receptor also, and it has a very, as we all know that vitamin D is an immunomodulator. Lots of our diabetes patient as well as the tuberculosis patient are severely vitamin D deficient. So what is your take on this supplementation of this vitamin D in view of long isoniazid therapy in type 2 diabetes with tuberculosis? And second is many of the TB control program, they are advocating the intermittent therapy, short-term therapy, and some of the therapies are available with the government offices only. So with the availability of drug only to the government institution and giving the drug as a intermittent therapy, how it is possible to eradicate tuberculosis within 2 to 3 years? That is a big question.
Thank you, sir. The first question was regarding the vitamin D. We know that one of the modulator is vitamin D, but the research says, the effect says, the data says that it should not be used routinely in the cases of tuberculosis. And there is not the very good data showing the result that if you give the vitamin D, the effect is good or the immunity is very high and the patient will not have that. But as you say, that even the 90% of we Indians who take the burden of 27% of world population, if we are deficient in vitamin D. Earlier we thought that हम लोग तो भारतीय हैं, इतनी धूपें मिलती हैं, इतना विटामिन डी एक्टिवेशन होता है, नहीं हम लोग आप ब्लैक हो तुम लोग यार, वहाँ पर तो ये हो जाता नहीं, अल्ट्रावायलेट स्क्रीन हो जाता है, जा ही नहीं रहा, विटामिन डी बनता है. Why we Indians have got deficient? 90% of Indians are deficient in vitamin D. For that, yes, should be given. You can try it, but the data is not there. That it should be routinely used as it is. Second part is that when this DOT therapy came and it said if you give rifampicin, there is inhibition of this tuberculous bacterial growth for 4 days. And that's why we give the thrice weekly doses. Professor Vinay Kumar is here. He raised this question, depicting, you said these are the theory. And after 2 years or 3 years, again went back to Dr. Vinay Kumar, sir, you were right, DOT therapy is bogus. In clinical effect, it has brought many cases of MDR cases. And you see now we have got sitting on the time bomb of MDR tuberculosis, and we are very much hard in that to eradicate that. We can eradicate the rifampicin sensitive TB. Yes, in that we have shed a lot of problems, I told you. In MDR, we have got 3 more combinations. Every 6 months, they will give another regimen. The BIPAL regimen, I said, when all these 5-6 drugs are not able to control the MDR treatment, and BIPAL regimen came, again the resistance will come with our lovely anti-TB drugs like quinolones. And then again the resistance is very much high. Bhagalpur data I say 50% of patients of tuberculosis, when we got the resistance pattern, they were resistant in quinolones. Bhagalpur data, our laboratory data, 50%. So there are many problems.
So one word I want to say about the vitamin D, because we do not know the exact level of the vitamin D. And I think this is hyped by the commercial houses. So only vitamin D is relevant for me when the calcium level is altered or something, we needed it for the bone health. But most of the things we do not have the right data supported by the public funding. We do not have. Most of the data which you see, the vitamin D, heart failure, vitamin and this, they all are promoted by some of these sponsors. So unless until we have the Indian data to say that yes, vitamin D is, level of vitamin D is this, which is a good or bad for that, we cannot say with confidence. Though we are writing, many of the time patient is pressing, अब देख लीजिए vitamin D कम है, अब दवाइयाँ नहीं दी हैं. So unless until we have enough of data, it's difficult to propose vitamin D. We are providing, but I see it as a patient happy, doctor happy approach.
So what I am saying is the twin problem, that is the tuberculosis and diabetes.
Yeah.
And isoniazid being a drug which is blocking the vitamin D at the receptor level, not of a blood level of vitamin D. Isoniazid can cause vitamin D deficiency, and it can cause even osteomalacia in the newer younger population. So in view of isoniazid being the receptor blocker as well as the consumer of vitamin D, and our population being vitamin D deficient, the larger studies would be planned. Vitamin D receptor variants would be studied, and accordingly the plan can be given. That was my question.
But that's
It has no role in diabetes. In diabetes with tuberculosis, and in the tubercular regime, isoniazid being one of the prominent. That was
What I wanted to emphasize upon Dr. Professor Ashutosh Mishra, vitamin D has been
Dr. Ajay, what I said, even without diabetes, in non-TB cases, we also advocate vitamin D in this administration. So if it is associated with diabetes mellitus, yes, but data is lacking. Data is lacking that all cases of TBDM should be routinely used this. Thank you.
Any other question? We have suited the time, and the sponsors are hinting that you saw it. So there may be more questions, sir, so we will settle it in the lunch period. Thank you once again for brilliant presentation about the Thank you, sir. There is another talk by the noted diabetologist of the town and very important person for the RSSDI BIHAR chapter, Dr. Kamran Khan. Very proactive, and his topic is also very important, diabetes and mental health. So how we should select the correct anti-diabetic drug in a person who is elderly, frail, or who is having a mental problem, and what is the connection between diabetes and mental health. Over to Dr. Kamran.
Thank you, Chairman sir. Am I in the safest hand? Have I chosen the right person? A patient has in his mind the first thing when he visits the doctor. So it is very important that we should discuss no data, no statistics, but for the patients. So here the intersection of diabetes and mental health we will elaborate. Yes, there is a disclaimer, but it is a sponsored talk. So what are the objectives of this? So the implication of stress in the context of diabetes, impact of emotional stress on the pathophysiology and diagnosis of diabetes, and role of emotional stress and various mind-body interventions in diabetes. So how this stress can affect a diabetes? So we have different kind of stress. We can have psychological stress, environmental stressor, and physiological stressor. And finally this stress grows and a state of threatened homeostasis develops. Repeated episodes of acute or chronic psychological stress can activate acute phase response and can trigger or can lead to this glycemic state in a diabetic patient. So we can have different dimensions of stress. We can have the timings of stress. The subject is either directly related to diabetes or other stresses in the context of diabetes, and there may be general stress. So what are the stress, acute diabetes stressors? Stressors related to pathophysiology or treatment of the condition can increase endogenous glucose utilization, glucose production, and impaired glucose utilization due to various things. And it can lead to treatment changes, new diabetes management device incorporation, and discrete blood glucose related events. And how the patient feels. Diabetes related stress can lead to powerlessness, hypoglycemia, disoriented, rather disturbed eating habits, and the patient starts self-management. Treatment regimen can be modified, and it is found in 20 to 40% of the patient with diabetes that diabetes stress is there. It is different from major depressive disorder, certainly. So elevated diabetes related stress is associated with poor glycemic control. There is a poll that is there any association between elevated stress and poor glycemic control? I think most of the answer is yes. So how does this stress impact outcomes in diabetes mellitus? There can be physiological and psychological factors. It can be leading to poor glycemic control, poor treatment adherence, poor self-care, development of depression and anxiety, and elevated inflammatory markers and CRP levels. And the emotional factors play a role on neuroendocrine mechanism. The role on HPA axis of stress can play a role. Brain insulin resistance. There is brain insulin resistance, a joint pathological feature of metabolic and cognitive dysfunctions. There may be augmentation in sympathetic nervous system, and stress is a potential contributor to chronic hyperglycemia and diabetes. Stress triggers the activation of sympathetic nervous system, and thereby the contrarregulatory hormones and catecholamines are increasing, and they can lead to hyperglycemia. So emotional stress leads to obesity, insulin resistance, and a reduced sleep. And definitely it is a established fact in most of the patients. There is obesity and insulin resistance relationship. Production of reactive oxygen species is there. Reduced sleep and insulin resistance evidences are there. HPA axis and mesolimbic dopaminergic system is affected by this. So the impact is that corticosteroids or glucocorticoids, HPA axis activation, and due to this physiological response to stress, and they can lead to hyperglycemia, or hyperglycemia can lead to this. This is the vice versa. So stress can cause hyperglycemia as well as other metabolic abnormalities such as obesity, dyslipidemia, hypertension, which may result in development of cardiovascular disease and atherosclerosis. So there can be differential diagnosis of hyperglycemia in the context of stress. Certainly the first one is diabetes mellitus. There may be stress hyperglycemia, as if you will check my blood sugar or someone who is going to speak, certainly it may be on the upper side. Cyclic Cushing syndromes or pheochromocytoma, which is rare, but it can give rise to a severe hyperglycemia. So these are the things, cyclic Cushing syndromes and pheochromocytoma, where hyperglycemia is a certainty. I am not going to elaborate it. So what is the impact of stress on natural history of diabetes mellitus? According to the ADA, both emotional and physical stress plays a central role in alteration in the A1C value, and diabetes-related stress is very common among individuals with diabetes, especially in youngsters with type 1 diabetes, because they have to live with insulin and bricks. Besides that, fluctuate in tandem over time, this HbA1c fluctuates very much, and dose titration and the management of treatment becomes difficult due to pre-existing stress or ongoing emotional trauma to the patients. Similarly, the chronic general stress and A1C has a correlation, that is strong correlations between chronic stressful life events and A1C in youth and adults with type 1 and type 2 diabetes is there. Other thing which can lead to neuroendocrine response, which can lead to poor glycemic control, is visceral adiposity, sympathetic activation of sympathetic nervous system, reduced sleep, and allostatic load. That means activation of HPA axis leads to various endocrine abnormalities such as high cortisol and low sex steroid levels. The psychological process, an important modifiable mechanism of glycemic control. We can modify it by therapy, we can modify it by proper counseling. Depressive symptoms and diabetes-related stress may amplify one another in relation to their links with glycemic control. Psychological process related to coping and stress management may buffer the stress A1C association. Health behaviors and self-management skills may either amplify or buffer the link between stress and glycemic outcomes. We talk about data and we talk about the efficacy and everything, but this hidden factor of ongoing diabetes, stress, or the emotional and personal life of the patient matters very much, and this should be addressed too. As I have seen a patient receiving full dose of therapy, despite that he is getting dysglycemic every time he comes to me. So stress within a family is associated with poor glycemic control. This is a very important factor in Indian scenario where the family disputes are there and they can lead to hyperglycemia and altered blood sugar levels. Several studies have found a strong association between A1C and stress related to daily regime or management of diabetes compared to other areas. Guidelines predominantly focus on medical management of diabetes mellitus without addressing the psychological needs of the patient. This is very important, sir. Psychological support in patients with diabetes mellitus is inadequate, resulting in poor quality of life and reduced general well-being. So early initiation of psychological intervention is instrumental in improving metabolic outcomes. We have our own unhealthy lifestyle behaviors like poor self-care and poor coping mechanisms. We don't have proper routine in our life, and that is another factor which is causing, which is giving the diabetologist a sleepless night for their patients to make them euglycemic or normoglycemic. So stress leads to poor self-care in diabetes, poor adherence to medications, poor adherence to diet and exercise, and poor monitoring of blood glucose. This is very important thing. Other things which are vices like smoking, as well as alcohol, low exercise endurance and levels, inadequate eating behavior in terms of quality and quantity of food, all these can lead to impaired sugar control. There is a study, French diabetes survey as well as the Dawn Japan survey, and all have measured the patient about their emotional status. Diabetes survey said that committed patients are only 25%, carefree patients are 23%, diabetes hai to hai, bitter are 19%, disheartened 19%, and overwhelmed 15%. So if we see only 25% patients are committed, rest are dwelling in some sort of dispute in themselves, in their mind, and this can lead to dysglycemia. Similar is the trend for the Dawn Japan study, that negative image of injections and positive image towards insulin therapy were significantly associated with patient decision to start insulin therapy. So low levels of positive psychological process can lead to worsening of HbA1c level, and there is a strong association between rising distress and worsening HbA1c across time, and we can certainly palpate it and see it in our day-to-day practice, how a patient with distress can never be a euglycemic patient. So there must be some intervention for those class of patients. So non-pharmacological interventions are and pharmacological interventions are. Now in non-pharmacological, there may be the support, psychological support, psychotherapy, counseling, family support, besides exercise, diet, meditation and yoga. And in pharmacological therapy, we can go for anxiolytics, we can go for low doses of SSRIs or antidepressants even, and by that we can improve the status of the patient's status of the glycemia profile. So psychological intervention is an integral part of diabetes care, but unfortunately we don't have a proper team to look to those things properly, or we don't have proper time to address the patient in that way psychologically. There may be cognitive behavioral therapy, there may be motivational therapy, problem solving therapy, coping skills training, family behavior therapy. कहाँ से आए हो, कैसे रहते हो, क्या इनकम है तुम्हारी फैमिली की. You have to be empathetic with the patient to have a proper glycemic control. So improved treatment adherence will take place certainly after we undertake these things, and there may be different improved glycemic control. Different level of stress can be there, level 1 to 5. Level 1 starts with small stress, and level 5 is severe and complex mental stress requiring intervention from a psychiatrist or a psychotherapist. So there must be a pragmatic approach for psychological interventions. A pragmatic approach should be followed for psychological interventions in the manner that there must be the patients must be having the time constraints or lack of defined behavioral strategies, and both it applies it to the clinician as well. And problem-focused coping and emotional-focused coping must be ensured. So, health belief model in diabetes management is the useful in explicating self-care activities such as diabetes management recommendations as per NPM when making a health decision, and individual's behavior can be predicted based on perceived susceptibility, perceived barriers, perceived benefits, and perceived severity. So a significant positive relationship has been found between perceived severity, perceived benefits, and diabetes management. So here is a poll that, in your opinion, what should be the recommended physical activity participation for persons with diabetes? We all know that 150 minutes or more per week of moderate to vigorous intensity activity is recommended, with stretch exercise for 5 to 7 minutes in between the work hour is recommended and most widely adopted worldwide. So this is the exercise regime. Otherwise, there may be recommendations that most adults with diabetes should engage in 150 minutes or more of moderate to vigorous activities. Children and adolescents with type 1 or type 2 diabetes should engage in 60 minutes per day or more of a moderate or vigorous intensity aerobic activity. Dr. Supriyo Mukherjee was speaking about this yesterday. Adults with diabetes should engage in 2 to 3 sessions of resistance exercise on non-consecutive days. It's very important to advise for lifestyle modification in proper way. Flexibility training and balance training are recommended 2 to 3 times per week for older adults with diabetes. Yoga and some other meditation should be advised. Besides that, nutritional recommendations are there for healthy diet and healthy food, and it is also very important as advised by FDA and recommended by FDA. And meditation is associated with reduction in stress and negative emotions. One should be asked to meditate. Of whatever religion they follow, they must be asked to meditate. If they are not doing anything, they should do yoga. If somebody from the Muslim community is coming to us, then they must be told to meditate for namaz, or Hindu community, for any of the community. Meditate for 15 to 20 minutes. It will release you, it will reduce your stress, and it will improve your blood sugar level also. So we have to look way forward. We have ABCD, incorporation of psychological screening and management of every level of diabetes care, sensitization of healthcare providers, patients and their family members about the importance of psychological screening and intervention, advocacy program at the community level to improve the awareness level of psychological well-being of a person with diabetes, and the need for more well-controlled, randomized controlled trials exploring mindfulness meditation in the management of diabetes mellitus. So key messages are: diabetes-related stress is associated with poor glycemic control. It is a fact. Stress can affect the pathophysiology, diagnosis, management, and natural history of diabetes mellitus. Health behaviors and self-management skills play an important role in the impact of stress on glycemic outcomes. Mindfulness-based stress reduction in diabetic individuals is associated with improvements in body weight, glycemic control, and blood pressure, as well as improvement in the quality of life. Thank you.
Finishing presentation at right time. Thank you very much. And you have highlighted the importance of mental health in diabetes mellitus.
It's very important, sir.
And there is a data which showed that the person who has having diabetes with major depressive disorder or schizophrenia, they die 14 years earlier than their counterparts. So diabetes, Yeah, and all are aware that diabetes with mental disorder will have problem. But it is an important problem, and particularly the person who is having the major psychological disorders. So there must be collaborative approach between diabetologist and psychiatrist. If you cannot handle for minor stress disorder, you can handle if you have enough time.
Yeah.
But in your busy clinic, when you are seeing more than 100 patients,
We must not.
yeah. So you have to keep in mind that yes, you have to make a collaboration with your neuropsychiatrist friend. Thank you, and house is open for discussion. Any comment, any question, or any? So I think Dr. Kamran Khan has taken all those things which are important for the clinical practice. Thank you once again, Dr. Kamran Khan.
Thank you. Thank you.
Thank you, sir. May I request other two speakers in this session, Dr. Sujoy Ghosh and Professor Dr. D.P. Singh sir, to please come on the dais. And may I request the chairpersons to honor our first speaker, Dr. Sujoy Ghosh, who has come all the way from Kolkata and delivered a brilliant lecture. It's wonderful to have you here, sir. Dr. Sujoy Ghosh. A big round of applause for Dr. Sujoy Ghosh. Next, I would request, sir. Next, I would request the chairpersons to honor our master speaker and master teacher, Professor Dr. D.P. Singh, sir. A big round of applause. एक सेकंड Can I book it for Dr. Kamran Khan?
क्या फोटो मिला तुमने?
He delivered a beautiful lecture. Thank you so much. And I'll request three speakers to please honor our chairpersons as well with a bouquet. सर इधर देखेंगे सर. Thank you so much. For the next session, may I invite the chairpersons, Dr. Avilesh Kumar sir, Dr. Mahesh Kumar sir, please come on the dais sir. Please chair the session, and Dr. Bharat Bhushan sir. All three chairpersons are from Bhagalpur, from Medical College, our own Medical College. So I request all the three of them to please chair the session, sir. And they will introduce the next speaker.
Now the next speaker is Dr. Vinay Kumar Gandhania from Diabetes Care Center Ranchi. He is Secretary of RSSDI Jharkhand State, Live Member RSSDI, DFSI, UDF, Red Cross, IMA, AIAARO. He is a member of Endocrine Society and ASE USA. He is alumni of ISB Hyderabad and principal investigator for ICMR India. Study from Jharkhand. In his name there are 14 publications in international and national journals, and he is a consultant diabetologist at Ranchi. Now I call upon Dr. Gandhania sir to start his.
Thank you, respected chairpersons for the very kind introduction. Respected seniors, dear friends, students, it's really going to be a very interesting presentation, very important in day-to-day clinical practice. And I'm thankful to Dr. Sujay Ghosh for giving me this topic for his meeting way back in 2019. And I still feel this is a very important topic, fever in diabetes. And we see a lot of problems, daily patients coming to your clinic with fever and having problems associated with it. This is adopted from Harrison's textbook of medicine, 21st edition. Fever is an oral morning temperature of more than 37.2, and PM, this is the normal temperature, and the evening temperature is 37.7 is defined as fever. So normally temperatures can vary up to 0.5 degrees Celsius in the same person over a day. Older people have higher, that is by 0.5 degrees Celsius temperature compared to younger people, and rectal temperature is 0.5 degree higher than the oral temperature, and the oral temperature is 0.5 degree higher than the axillary temperature. A high body temperature or fever is one of the ways our immune system attempts to combat an infection. So impaired immunity makes diabetes prone to getting fever, and fever in a diabetes is a cause for most of the acute complications like DKA, HHNK, and even hypoglycemia. This is how it is very critical that we should take care of fever very significantly, and it has got a little different approach as compared to non-diabetic population. So for this presentation, we'll talk about the association of infection in diabetes, pathophysiology of infection in diabetes, common infections in diabetes, and management approach with some preventive measures like immunization, and then final conclusion. So diabetes prevalence is on the rise. Why I have kept this slide is, we know that our rural population is 2/3 and the urban population is 1/3. And if you see the prevalence of pre-diabetes is very similar in both urban and rural population. And with the urbanization of the rural population, we are actually Sabka Saath and Sabka Vikas is going to create more number of diabetics in the rural population, and the numbers are definitely going to increase much more in the rural population compared to the urban population. So, and what infection we see from the rural population is very high, because there are multiple factors associated with it. So infection and the fever, infection and the problems of acute complications are going to be more seen in days to come because of the number of patients increasing in the rural population. Even today in our clinics, we see a lot of patients coming from the rural population, and they literally come at a later stage or complicated stage of the disease, which becomes very difficult to treat them, and the cost of therapy to treat these people coming from the rural population is also very high. So it's again very important that we need to address this population very strongly as far as preventive measures are concerned. So this is my case one. 10-year-old male child, type 1 diabetic for last 5 years, has fever since last 2 days, is brought to the emergency with complaint of breathing difficulty and vomiting. His mother says that since the child is not having food, he is not able to give insulin as advised. The child has been admitted and diagnosed to have DKA due to omission of insulin due to febrile illness. The child has been well treated and planned for discharge. Now what is very important here is, how could this serious acute complication could have been prevented? This is what is very important. And that is what is important is your sick day regimen in the patient with diabetes. It's very important that all your diabetics should learn this sick day regimen. A sick day is when patient has an illness or infection and need to make changes to usual diabetes management to keep blood glucose levels in the target range, and these changes are usually not only needed until patient is well again. And let me tell you here, the role of ACMBG or the role of your glucometer and blood sugar testing, repeated testing makes a very, very important breakthrough, and both the patient, child and the parents should be taught about it. During sick days, blood sugar increases and increases the chance of ketone bodies formation. And today we have longer acting insulin analogs, and with the use of longer acting insulin analogs, even the chances of hypoglycemia has increased in patients during sick day regimen. Frequent blood sugar checkup is needed every 3 to 4 months, and if blood sugar is high, rapid acting insulin should be additionally given 2 to 3 units, can be given every hourly. Even if the patient is not taking orally, if the sugars are high, you can inject them and keep monitoring it. And let me tell you, if the blood sugars are very high, the child is not eating and you are not having access to hospitals nearby, you can teach the parents to give an intramuscular insulin. That is also very, very beneficial at this particular time, because during dehydration, state of dehydration and ketosis, many a times the absorption from the subcutaneous side is impaired, and that is where the role of intramuscular insulin is helpful. You can inject over the pronator muscles over the forearm and can be taught very, very easily. Instead of injecting like the subcutaneous on the hand, you can straight inject over the muscles, and that is also very, very beneficial in those sick period. Blood ketones or urine ketones should be checked. We have a glucometer from Abbott which gives both ketones and the blood sugar levels that can be actually prescribed, especially to the type 1 diabetic patients. It's a very, very useful glucometer. Common symptoms and alarming signs of decay should be explained. It is important to take more fluids and carbohydrates to prevent hypoglycemia as well. So that is what is sick day regimen is very, very important. Sick day regimen is important in most of the hormonal diseases, like even in Addison's disease is also very, very important when patients are on long-term supplements of steroid therapy. Even patients with other disease also, like sick day regimen is very, very important. So it's very important that fever needs to be tackled in type 1 diabetes, and sick day regimen should be taught to each and every parent with type 1 diabetes. Case 2 is a 60-year-old lady, known case of diabetes since last 12 years, is brought to the casualty with complaint of high-grade fever since last 2 days, loss of appetite, giddiness and drowsiness. Her vital parameters are like this: temperature is 39.8, pulse rate 122, blood pressure is 100/70, respiratory rate is 26, SpO2 is 80% with the blood sugar random in the casualty at 450. She has been shifted to intensive care unit for further management. This is a very, very routine case in a corporate hospital or a government hospital. Almost daily, some patient you will find with this type of scenario. Now, infection in patient with diabetes is a real big problem. Association between diabetes and increased susceptibility to infection is not supported by strong evidence, but many specific infections are more common in diabetic patients. Some occur exclusively in them, and other infections occur with increased severity with an increased risk of complications. So this is what is the normal immune response. We heard even in the previous lecture by Dr. D. saying that the normal chemotaxis, phagocytosis, bacterial destruction, the IgG fixation of complements, which is there in the normal population, is impaired in patients with hyperglycemia. This is what is very, very important. There is a decreased chemotaxis, there is a decreased phagocytosis, decreased bacterial destruction, decreased IgG fixation of complement. Now, why this learning is very important is, I can give you a very simple example. Patient comes with a HbA1c of 12.5 and 13%, and it's been planned for the surgery, like a cataract surgery or a elective surgery. And the surgeon wants that your blood sugar should be controlled in 7 days time and 10 days time. Fine, you can control the blood sugar for 7 days time and 10 days time. But the risk of inflammation and infection doesn't go down in 7 days time and 10 days time. You need to explain to the surgeon, you can operate with a blood sugar of 100 and 180 after 10 days. But since your immune response was grossly impaired with a high blood sugar, you may not have the advantage of anti-inflammatory and the anti-infective advantage of good glycemic control in 7 to 10 days time. This is what is very, very important to explain them. So this is what you need to understand about the hyperglycemic immune response. These are the major infections associated with diabetes. the respiratory system, streptococcus pneumonia, influenza, H1N1, tuberculosis, and to add even COVID here. Urinary tract infections, asymptomatic bacteria is very important, because if you have someone with an asymptomatic bacteria, I would request not to use drugs like SGLT2 inhibitors in this class of drugs. Fungal cystitis is also common, emphysematous cystitis, bacterial pyelonephritis, perinephric abscess, prostatic abscess in males, and pyometra in females. They are all pretty common infections which we see in day-to-day practice. Head and neck infection, invasive external otitis, otitis externa is also very signature infection of diabetics. It's caused by Pseudomonas. Rhinocerebral mucormycosis, which has become very popular during the COVID time. GI and liver infections like H. pylori infections. We keep giving antacid to our diabetic patients. We feel maybe drug induced, but I tell you H. pylori infections should be ruled out. Ask your patients to undergo for OGD scopy and an H. pylori infection test, and you can actually treat it. Don't keep giving them Pan-D or pantoprazole or domperidone combinations for lifelong. Oral and esophageal candidiasis is also very common and very easy to treat. Emphysematous cholecystitis, hepatitis C and hepatitis B. The enteroviruses infection is also common. Skin and soft tissue infection is very common. Foot infections, as I was talking from the rural population, is very common. Necrotizing fasciitis. Fournius gangrene is also not uncommon, especially elderly people who are dribbling, who have incontinence of urine with high blood sugar have Fournius gangrene, chances of getting Fournius gangrene. Other infections like HIV is also common in diabetics, almost twice common in diabetics than non-diabetics. Diabetics patient represents 20 to 22.7% of all patients with sepsis. So you can understand if 5 patients are admitted in a casualty, almost 1 patient is a diabetic in a hospital. The risk of LRTI, the risk of UTI, skin and soft tissue infections is very high, and 30.4% of the diabetic patients exhibit infections. Most of the wound infections, UTIs or pneumonia, very common. So it is very important to understand to take care of this. Diabetic patients are at a higher risk of reactivation of TB and poor outcomes, and we heard a very good lecture and interactive session by Dr. T.P. Singh. Diabetics and pneumococcal pneumonia are more likely to be bacteremic or die from it. Very difficult to treat. People receive 4 antibiotics, 5 antibiotics, antifungal drugs, whatnot, but it's very difficult to treat. Asymptomatic bacteria is again a real big problem. Diabetes and the risk of the mortality is very high in diabetics, as I was talking about, almost twice than the non-diabetic population. Nosocomial blood stream infection. I've seen recently a couple of cases of Acinetobacter infection after hospitalization, and patient never survived after that, and they received all possible antibiotics which are available in the hospital setup. Sepsis is again a real big problem, and there are a lot of explanations. High blood sugar, there is a increase in non-steroid fatty acids levels in the blood, high level of triglycerides, and all these things make you prone for sepsis, and sepsis induces multi-organ dysfunctions in a diabetic patient. So diabetes mellitus, hyperglycemia will cause a vicious cycle, decreased immune response, increased susceptibility, infection and hyperglycemia. So infection results in uncontrolled hyperglycemia and other infections. This is one case which I have seen very recently, some 6 months back, and I want to present this. A 50-year-old lady, non-diabetic for last 10 years, has come with fever, low grade since last 1 month, weight loss and poor appetite. She has visited multiple clinics and diagnosed to have UTI. Her cultures done twice is positive for E. coli. She has been already received different antibiotics but has no relief. She is on OHA for blood sugar control with HbA1c of 9%. CBC, KFT, LFT, X-ray, ultrasound are not significant. This lady was really frustrated. मेरे को B. coli हो गया, मेरे को B. coli जाता नहीं है. I mean, she was really frustrated. Urine has trace of albumin and pus cells of 6 to 8. Then finally we did a urine PCR for ALP, and which was positive. So what I mean to say is extrapulmonary tuberculosis is also very common in diabetes. Like port spine is common, like genitourinary tract tuberculosis is common. We need to actually look, even simple lymph nodes, lymphadenitis are also very common. And good glycemic control and AKT was given as per the protocol. So infection, tuberculosis is very common, and I'm not going to discuss on that. We had a very good lecture, and Even pre-diabetes is also a has got a similar risk factor like a diabetic and tuberculosis, and all tuberculosis patients should be evaluated for diabetes. Diabetic food, and one thing I want to add upon the previous lecture is every sputum positive diabetic should receive a mask, and the whole household should be advised to isolate for at least couple of months. That is how we can eradicate tuberculosis and spread of tuberculosis, because people don't use mask, even sputum positive people don't use mask. Diabetic foot infection is again a very big problem for fever in diabetes. I can tell you, people come with a normal skin, normal foot, they have osteomyelitis inside. डॉक्टर साहब ये तो हमारे पास 2 साल से पुराना प्रॉब्लम है, इसमें अभी कुछ तकलीफ नहीं होता है. But you do an X-ray, you will find a gross osteomyelitis of the great toe, metatarsals, and that is one cause they keep getting low grade of fever, loss of appetite and weight loss. So you need to evaluate even a asymptomatic foot infection in a diabetic. Antibiotic resistance is also a real big problem. Let me tell you, very big problem. You do a urine culture, you will find one cholesterol and one polymyxin and very high antibiotics, 3rd generation and 4th generation, only sensitive to the organisms, and it's very difficult to treat. So antibiotic resistance is again going to be a big problem in a diabetics in near future. Prevention is a real key thing. For prevention, hyperglycemia should be corrected and should be controlled, and we have data to support that patients with a good glycemic control have lesser admission in the hospitalization and has a better outcome as far as treatment is concerned. In the ICUs, the blood sugar concentration should be close to more than 180 should be treated, later maintained between 140 to 180, and non-critically ill patients try to keep a blood sugar of less than 140. This is the recommendation even by our RSSDI national guidelines. This should be our target blood sugar levels. Immunization is one thing which we need to stress upon. Why I have added this is one area which has been ignored in our day-to-day practice. And adult immunization is very important to prevent critical infections in our diabetic patients. And I heard even for tuberculosis, I heard by Dr. T.P. Singh is also looking forward for a immunization to prevent tuberculosis. All adult diabetic subjects should be educated about administering pneumococcal and influenza vaccine. This is very easily available. You need to write on your prescription, and you should make an immunization card for all your diabetic patients, even with CKD and diabetes. I've seen nephrologists prescribing a very good prescription for hepatitis B vaccination, but they I don't know why they don't cover about the pneumococcal and the influenza vaccine. That also needs to be included. We have enormous data and recommendation and guidelines to be included in day-to-day practice. And children with diabetes type 1 of more than 2 years of age can be given pneumococcal polysaccharide vaccine, and children above 6 months of age can be given. I'll take 1 or 2 more minutes, 2 minutes more. Other vaccines may be administered in diabetics as per the recommendation. This is what about the annual influenza immunization. People were taking influenza vaccine when we were not having COVID vaccine. If you remember, in the first year of COVID time, people were all taking influenza vaccine when COVID vaccine was not available, thinking we'll have some cross immunity. But this is very easily available, the inactivated influenza vaccine, the live attenuated influenza vaccine. Today we are having a epidemic of 3 virus infection at one time, COVID, then we have H1N1 and we have flu, all 3 going on together in our communities, very highly prevalent today. And we have very good data to support that influenza vaccination was associated with a 56% reduction in any complication, a 54% reduction in hospitalization, and 58% reduction in death. This is a real robust data to have benefits of this particular immunization. Is to be given annually. Similarly, pneumococcal infection can be prevented by giving these vaccinations. They are very easily available. One comes from the Pfizer, the other comes from the MSD. Both are available everywhere. This is the pneumococcal polysaccharide vaccine, and this is the pneumococcal conjugate vaccine PCV13. Dose is 0.5 ml injected over the deltoid muscle. A one-time vaccination is recommended for individuals 65 years of age or older if previously immunized, and can be repeated after 5 years of age. Hepatitis B and diabetes is also very important. All patients should be asked regarding their immunization for hepatitis B. If not, they should be immunized as per the recommendation. 0, 1 and 6 months booster dose, not totally if the patient is not immunocompromised with CKD, or 4 doses if patient has having CKD and on dialysis. Similarly, DPT vaccine can be given in a diabetic patient if needed. This is also been recommended today in the guidelines. People who are traveling, they should have these vaccinations been given: hepatitis A, meningococcal, typhoid vaccine, yellow fever, Japanese encephalitis, and today even they look for the COVID vaccination as well. So this is a checklist for immunization. If animal influenza, pneumococcal, revaccinate for pneumococcal, hepatitis B, DPT. So this is how you actually look for the adult immunization. The important thing is should be given by to the right patient, right drug, right vaccine, right dose, right route of administration, and right time is also very, very important. So to conclude this presentation, fever is very, very common in the diabetic population. Infectious disease is the commonest cause of fever and are more frequent and more serious in patients with diabetes, which potentially increases their morbidity and mortality. Infections may be the first manifestation of diabetes mellitus or the precipitating factors. Let me tell you, almost 30% of the patients either present with vulvovaginitis or pyelonephritis during the diagnosis of diabetes. Either they have been picked up by the gynecologist or by the urologist to have high blood sugars. Infection may be the first manifestation in those people. Good glycemic control prevents infection in patients with diabetes. We have enormous data to support that. And I thank you all for this presentation listening, and I thank the organizers for giving me this opportunity and inviting me all the way from Ranchi to Bhagatpur. Thank you very much.
Thank you, Dr. Dhandania from Ranchi, for excellent topics about fever in diabetes. Basically, this fever in diabetes is due to infection, and in diabetic patient there is a decreased immunity, there is a decreased polymorphonuclear function, there is a this high level of sugar that increases the growth of microorganism, and that is responsible for fever. So this infection is mainly responsible. There is a skin and soft tissue infection which is more common in diabetes, like furuncle, boil, carbuncle, respiratory tract infection regarding pneumonia, tuberculosis, both pulmonary as well as extrapulmonary tuberculosis. Second, the lung abscess, empyema are more common in diabetic patients. And urinary tract infection like cystitis, pyelonephritis, perinephric abscess are more common in diabetic patients. And even diabetic food is common, and this diabetic food is due to sensory neuropathy, due to neuropathy, and this is due to peripheral vascular disease, which is also responsible. Even the immunity, decreased immunity, that is responsible, and the high level of glucose, which is a favorable media for the growth of microorganism. These all infections are responsible for fever in diabetes. Thank you.
Thanks, sir, for the excellent talk. One thing is very important in case of diabetes, that you have said that the vaccination, this portion must be taken care. And second thing, if the patient is suffering from fever, few diseases must be excluded that are very, very dreadful in case of diabetes, like the rhinocerebral mycosis, that is very prevalent in case of corona era. And second one is the UTI, that is the kidney infection, that must be cared. And third one is the hepatitis external. You have explained everything very nicely. Thank you, sir.
In a patient with fever and diabetes, how long should we wait
I think if you do an early surgical intervention, you will have a better glycemic control. It should move parallelly. Your blood sugar control should be initiated, and if you have an abscess, you need to drain it as early as possible. I'm talking about the elective surgery. I'm not talking about the emergency surgeries like abscess or diabetic foot. I talked about something like elective surgery. When you are planning for a hysterectomy, when you are planning for a cholecystectomy, asymptomatic cholecystectomy, asymptomatic hysterectomy, cataract surgery. Now, why a cataract surgery? What is the biggest problem in cataract surgery? Is inflammatory reactions after the implant, isn't it? That inflammatory response is not going to be corrected by a 7-day treatment of your diabetes. It will take at least 6 weeks to 2 months time to correct the immunomodulatory changes which has happened because of hyperglycemia. So that is need to be explained to the surgeon. Yes.
Documented that it requires 6 weeks to 2 months. It is a very specific term you are using.
It's the Alberti textbook of diabetes, and it was published in 1997. There are 2 volumes of Alberti textbook of diabetes, volume 1 and volume 2.
There are 2 kinds of surgery.
Even
we get referral from the.
yes, sir. This is what I'm quoting from that textbook of diabetes.
It is from 97 perspective.
Exactly. I'm talking about from the textbook of diabetes. See, the basic science of diabetes is not going to change whether it was 97 or whether it's 2023.
I'm not asking
Yeah,
you that.
yeah.
I'm not challenging you. It is the quote is from the Alberti.
Yes.
And
No, it's from the textbook of diabetes.
textbook of
That's written by Alberti and the group of.
And it is 6 weeks to 2 months is a time for elective operation to go.
Yes, after correcting hyperglycemia.
Okay. And
Yeah, we get referral from 2 types of patients, for 2 types of patients. One is elective, what you have rightly mentioned, and one in emergency. In emergency, hyperglycemia is never a contraindication.
Yes, sir.
The only
Yes, sir.
contraindication is ketoacidosis. If your patient has ketoacidosis, you have to correct for ketoacidosis, and then you go for emergency.
In fact, acidosis need to be corrected first, and then you operate.
Yeah, for elective surgery, what he has said, that if there is no emergency, yeah, you have to be, it's not only glucose control that is going to protect your outcome of any surgery. So wait for some period, and what he has suggested is better to opt for the elective surgery, if there is no emergency, for 6 weeks or more than that.
what is the multivalent pneumococcal infection, pneumococcal vaccine you prefer in adult?
In adult, I prefer the variant at 13 variant by Pfizer.
Because we don't have any data with 23.
Yeah.
That is what I wanted to emphasize in this point.
But it can be repeated, once you are repeating after 5 years, you can go for the polyvalent 23 as well.
And what is the signature, Dr. Gadania, it's a wonderful talk you have presented. What is the signature infection, if you say that, a signature infection which leads you to investigate for diabetes in a patient who is 17 to 30-year-old and non-obese? You understand my question?
Whether you want something
Well,
like.
it is around 17 to 30 year of patient comes with an infection, sick, and you feel that okay, we should get a blood sugar done.
You are talking about renal abscess, something like that?
A very important question. That is a 17 to 30-year-old person.
He's a non-diabetic.
Non-diabetic.
Yeah.
He comes to you,
Yeah.
and the infection which you saw, evaluated, and thought that you must get a blood sugar done. What is the signature of blood sugar? Yeah.
So I said that.
No. That is the question. That is the point which we have to emphasize in this.
And then you all balanophysitis at the time of diagnosis, all vulvovaginitis at the time of diagnosis should be evaluated for blood sugar.
At the very point.
Yeah, it's a very pertinent question because that is how the patients have been picked up.
Before you
That is the point which it must strike in our mind, that this might be a person is living with diabetes.
See, I'll tell you one thing. You ask a patient coming to your clinic, first time diagnosed with diabetes, you do a HbA1c and you find it's 12.5 and 13. You ask him, पेशाब के रास्ते में कभी कट जाता है, itching होता है क्या? सब पिछला 6 महीना से होता है, ऐसा हम दवा दुकान से मलहम ले लेके लगाते हैं ना, ठीक हो जाता है, फिर बार-बार हो जाता है. आपको कैसा समझा? You understand? So
signature infection.
That is a very common infection. And both the partners usually keep sharing the particular infection and they enjoy it basically. कि दोनों को ये प्रॉब्लम है तो किसी के में कोई बीमारी नहीं है. Because they think about STD, sexually transmitted disease.
Thank you, Dr. Dandania, for your excellent deliberations and very good interaction among learned people here. Now, I call upon Dr. Ashutosh Mishra from Varanasi. His topic is a blast of the past to tame time with think food and therapeutics. Welcome, Dr. Ashutosh Mishra ji.
Thank you, sir. And at the outset, I would like to thank the secretary, the chairman, the all organizing committee of the Bihar RSSDI. When I was asked to present a topic over here, I was thinking that I should prepare for a cardiovascular disease, a renal problem, or I should go for some fancy molecules or fancy mechanism. So what I thought, it is better to teach how to retard aging so that we can live together for a longer period of time and be happy for longer period of time. So that is a topic of interest. Everybody will like to live longer life, disease-free life, and a life without comorbidities. So that was the point. And we all know that age is the strongest risk factor for the chronic disease, and the hypothesis is if you retard the aging process, you will decrease the burden of disease. So that is one thing. So earlier, what was the hypothesis? We used to treat the specific disease, like if you are a diabetes, you are giving treatment being given for the diabetes. If you are a cardiovascular patient, your treatment given for the cardiovascular disease. But nowadays the paradigm is shifting. If you are a diabetes, be careful, you must be having some renal problem, you must be having some cardiac problem. So why not to intervene in a manner that the comorbidity as a whole can be reduced and life can be prolonged. So that is the idea, to initiate the intervention in an asymptomatic patient, in a middle age person like me, to enhance the quality of life. That is the basic thing, and this is the direction, believe me, this is the direction where all research is going on, and maybe 10 years down the line we will have a lot of talk in this area, and every specialty will eventually fuse into the medicine. So that is the thing, and you have to talk about the interaction between cardio, diabetes, renal, hematology, immunology, and everything, and eventually you have to have some solution which will modify all these regulatory things. So I will be talking about the immunomodulatory anti-aging processes, the hallmark of aging, that is a questionable thing, how to affect the aging by dietary restriction. It is not doctor, it is aging. So DR means by dietary restriction, not doctor. So metformin and aging, the metformin being talked about, it's not a #1 drug, but still it is a very useful drug. SGLT2 inhibitor and aging, this is a champion of the diabetes treatment. GLP-1 receptor agonist, again another all-rounder. And the other immunomodulator drug, anti-cancer drug, in high dose they are anti-cancer drug, in low dose they are immunomodulator. And circadian rhythm, this is very, very important, the chronomedicine and how they affect the longevity, and gut microbiota, again a very, very important topic nowadays, and we are going towards the precision medicine, and in the end we will find out why it is important to attend a conference. Because if you are attending a conference as a doctor, you will increase your life. And I will prove this at the end of my presentation. Be here with me. Okay. So this is the timeline and this is the research. Earlier, what was known about the India, that Indians used to eat very less. They are fasting too much. They are not very fancy and they are not very strong, but they are very, very intelligent and they live longer life and they live quality life. That was the statement for the foreigners, for the Indians. That was our legacy used to be. And why it was there? It was there because of the structured, the intermittent, the structured way of fasting, the structured way of sacrificing, the structured way of thinking, the structured way of sharing. So that is one thing which is very, very important. So earlier the research started with the calorie restriction, then to the mitochondrial dysfunction, then immunomodulation, and ultimately now we are here with some of the therapeutics, probable therapeutics which can increase the life, and probably the combination of the drug to increase the longevity and the quality of the life of the patient. So before going into that, this is the definition of aging. Aging is a biological process that characterized by time-dependent cellular function decline, and the fragility is also a state characterized by low overall physical activity, decline in multiple physical system, and your increased vulnerability to stress-induced factor and resulting in physiological disability. So these are the two terms which should be very clear. But one thing, if somebody is born with a good gene and somebody who is born with a good regenerating power and he is having less risk factor, then obviously he will live for longer life. But suppose somebody met an accident, suppose somebody is living in a city where pollution level is very high, suppose somebody is in a very stressful condition, having very bad food habit, forced to do because of the circumstances, his aging process will be accelerated. So these are the things. So the time to recover the damage, these two things decide whether you are aging fast or you will age slow. So that is one thing. Another important point is physical, cognitive, social and behavioral part are the four important components of the fragility. And you must have been seen that the people who are in the geriatric population, their muscle strength goes down. And nowadays there is a lot of talk about the sarcopenia, the SGLT2, whether it is improving sarcopenia or it is not improving sarcopenia. But one thing is very sure, if your patient is having good muscle strength, he is going to live longer. That is one thing. If your patient is able to walk faster, he is going to live longer. So these are few things. So sarcopenia, the fragility, they can be measured by different parameters. All these parameters you can see, but in the nutshell, you can see that this is the sarcopenia and fragility is actually the similar thing. It is the same thing of the two facets of the same coin. So sarcopenia is very, very important. Take it as a generalized disease. It is there in cancer. It is there in heart failure. It is there in COPD. It is there in depression. So sarcopenia is not related only to the diabetes. It is related to chronic condition. So it should be taken like this. So what is the hallmark of aging? The Alzheimer's disease, cancer, kidney disease, heart problem, autoimmune disease, type 2 diabetes, immune dysfunction, the cognitive decline. So these are the hallmarks of aging. If these multiple factors are present, you say that, oh, ab to buddhe ho gaye, nahi? So what are the mechanism of aging? So mechanism of aging, if one line one can say that it is the maladaptive process of bad repair. That's what it is. So if something has gone wrong and body is trying to repair this, in that repairing process, some inflammatory proteins are released, and because of this inflammatory reaction which is not being controlled, ultimately it will lead to the diseased aging. Or if it is covered and it is controlled in a autophagy or senescence manner, than it is healthy aging. So that is difference between the diseased aging and healthy aging. So these two things, and it is mainly governed by three things: mitochondrial dysfunction, nutrient sensing pathway, and epigenetic changes. Like if you walk, a lot of methylation take place, the epigenetic changes take place, that changes the gene. Even a father walks, his child will have a better gene, better methylated chromosome will be transferred. So that is one thing. So with all these three processes ultimately lead to the chronic disease like type 2 diabetes and Alzheimer's disease, heart problem, NFLD, all the mechanism is same. So what I am telling is the mechanism of all chronic diseases are same and they are interlinked. So we have to modify the things at the common pathway level so that we can retard the development of these chronic disease. That is the thing. One theory is that there is accumulation of iron and copper inside the cell which will alter the redox potential, the NAD-NADH ratio, that will lead to aging. That is a very preliminary theory, but overall everybody will agree that the aging hallmark consists of 9 different processes, and these 9 different processes are at the cellular level, at the stem cell level, the alteration in the intracellular communication, at the molecular level, the genetic instability, the telomere length, epigenetic alteration, loss of histone protein acylation, the autophagy defect, and mitochondrial dysfunction. So these are the mainly hallmark of aging. So once there is a research, if somebody is aging fast, all these 9 parameters should be measured. And unfortunately there is no way to quantify it, which should be weighted more, or overall there should be a scoring system, but unfortunately at present there is no scoring system to assess the hallmark of aging, and neither there is a way to assess with the help of different biomarkers. So it's all subjective perception, and fortunately or unfortunately AI is also involved in it. So computer may also like to tell you how old you are. So that is one thing. So if all these 9 parameters are abnormal, there can be chronic disease, and unfortunately with these 9 parameters there is thousands of the down regulatory pathway. It is very, very difficult to remember all these pathways individually. So what is the solution? The solution lies here. This is very simple thing. If somebody is doing calorie restriction, the AMPK pathway and the citrulline pathway will go up, and if somebody is taking more food, then mTOR pathway, the growth factor, insulin, IGF pathway will go up. So what I used to tell my patient, like, look, how much you live depends upon how much food you consume throughout your life. The consumed food is constant. If you consume it faster, your life will be shorter. As simple as that. So calorie restriction is very, very important. So we little bit more expansion, the GDF15, another molecule. It is very, very important. This is another biomarker of potential biomarkers of aging. So it is increased by metformin, and that will suppress the appetite. The GDF is one thing which can predict COPD. The GDF is one thing which can predict heart failure. GDF is one thing which can predict the atherosclerosis. GDF is one thing which can predict the NFLD. It can predict the COPD. It can predict the cancer. So overall, it can predict the aging process. So it is a potential marker. Apart from this, the FGF21 is also important in this regard, as this is a molecule which can act on brain and intestine to induce favorable change, which are anti-aging change by suppressing appetite. So apart from all this, look at this picture, everything will converge at mTOR. So mTOR is very, very important. So the mTOR is connected with the various pathway, be it insulin growth factor pathway, metabolic pathway, hypoxia-induced factor, FOXO pathway, or the PGC1A, that is the related in the liver, or AMPK pathway. All things are interrelated and they are converging towards the mTOR. So mTOR is very, very important, and it sends various environmental signals. Like how yoga is helping, actually it is changing the MTOR, as simple as that. So it has got various physiological function and various physiological maintenance function. So MTOR can be divided into MTOR1 and MTOR2. MTOR1 is rapamycin sensitive. So it is basically regulating the autophagy and metabolic pathway. The MTOR2 is basically regulating the sarcopenia. The sarcopenia is very, very important and it is related to the FOXO pathway. So here is the number of diseases mentioned here that can be treated or modified once MTOR can be modified. So this is the beauty of MTOR. So what about the biomarkers of aging? As I have told you, GDF15, HbA1c, interleukin 6, cysteine-C, these are BNP, these are important. How fast once somebody is walking, the variability in the physiological function is very, very important. Like how much your pulse is varying once you breathe in and breathe out. How much your visit to visit variability of blood pressure, visit to visit variability of blood sugar. The variability of physiological parameter predicts the aging. That is one thing. It tells you that something wrong is in hemostasis. That's why it is fluctuating more. So variability is one of the important parameters. The AI driven parameters are also there. The cognitive parameters are there. So the sign of aging is the increased waist circumference. So if the person is young, subcutaneous fat is more, the VAT is less, the visceral abdominal fat is less. Once the aging continues, the visceral abdominal fat increases. And how it occurs? It occurs because of the adipose progenitor stem cells. They are defective, they are not able to divide. And that's why there is release of defective protein and ultimately inflammation. And that will lead to leaky, malformed adipocyte, and that will lead to inflammation and all sort of chronic metabolic disease. And this is depicted over here. I am not going in detail because of the lack of time. Here the senescence and aging is also important. There are so many pathways, but one thing is very, very important, that you have to modify senescence by multiple level, by multiple drug. So no single drug is going to retard the aging process. You have to combine 2-3 agents to retard the aging process. So that is one thing. There are first level of anti-senescence drug and there are second level of anti-sensing drug. Anti-senescence drug, mainly they are acting on the inflammatory protein released by senescence. So they clear it off. Second generation, they not only clear it off locally, but they also act systematically to remove from the other organ. So these two are very, very important, and these are the 4 classes of anti-senescence drug. Chronomedicine. Again, it is very, very important. If somebody is having mismatched central clock and peripheral clock, he will have diabetes, cancer, obesity, NFLD, COPD, and whatnot. So, the dissociation between central clock and peripheral clock is the main problem, and if you correct that, if you align that, the aging process will be retarded. And here you will see that there is a relation of these clock gene with nutrient sensing pathway and metabolic pathway. These are related with the circadian gene. So this is very, very important. And once the person is young, these modulation of the day and night variation of cry gene and the prey gene, they are very prominent. Once the aging occurs, the fluctuation become less. But if you time this thing with appropriate food at appropriate time, like taking your meal mostly at 7 o'clock, you can again restore the rhythm. Again, the type of food is also very, very important. So circadian rhythm, optimal drug timing is also important. Everybody is talking about SGLT2 inhibitor. If somebody is taking SGLT2 inhibitor at night, it is hardly going to affect the circadian rhythm. Morning SGLT2 inhibitor will restore the circadian rhythm and it will eventually correct it. If somebody is taking metformin and then exercising, the circadian rhythm will be lost. So there is relation between the metformin and exercise because of the AMPK pathway, because of the caloric mimickers and calorie restrictors. So circadian rhythm are very, very important. The last pathway is the Klotho pathway. Here you will see the FGF21 is important appetite suppressor, and FGF23 is a molecule because of which calcification takes place. So there is increased coronary calcification scoring, and there is lots of adipocyte formation once there is defective these two hormones, and there is increased aging. Gut microbiota. The gut microbiota is mature at the age of 5. Due course of time it declines. At the age of 70, the diversity of the gut microbiota is lost. Gut becomes leaky. There is abnormal molecule which is absorbed that causes immunomodulation and inflammation, and that will ultimately lead to aging and death. Lots of molecule like metformin, or you are taking some other drug. All these modify gut microbiota, and even statin, aspirin, GLP-1, acarbose inhibitor, the SGLT2 inhibitor, all modify gut microbiota. So, if you want to retard aging, you have to hit all 6 processes. And this can be done with the small molecule, reprogramming, the stimulatic therapy, and active health. So, let's see the Japanese people, what they are consuming. You can see here the good thing, bad thing, and you will easily point out that they are consuming less calorie, and their food is lot of nuts, seeds, and legumes. Give me 5 minutes, only 5 minutes. So lifestyle interventions are very, very important, and if somebody is restricting that, there can be positive changes, and these changes are proven in both animal and human model. So hallmark of all these dietary restrictions are there with the cardiovascular disease and extra-adiposity disease, but how it is mediating, it is not known. So research is needed in this area, and precision nutrition is very, very important in this. So not every calorie restriction is going to work in each and every people. Depending upon your ketone body level, depending upon your blood sugar fluctuation, the type of diet restriction will change. So this is very, very important. So we are going towards the precision nutrition. So this is the slide which shows that what are different hallmark of aging and what are different drugs which can affect it. So these are the 3 molecules which can retard aging: the resveratrol, rapamycin, and metformin. So metformin is very, very important drug in this regard, and it will suppress appetite. The metformin is antibiotic. The metformin is anti-inflammatory. The metformin can suppress appetite, and metformin can change the gut microbiota. So if you are giving metformin after surgery, so the 8-week duration can be reduced into 15 or 21 days duration, because it affects the anti-inflammatory thing. It can increase the survival over a period of 6% and 25%. So a lot of evidence from the DPP trials. Here are the different metformin trials. You can count around 13-14 trials are there on aging, and one of the important trial, this is the last trial, that is the TAME trial, and it is undergoing, and it's over a period of 4 to 6 years. The metformin will be given to the healthy people to look at the impact of chronic metabolic disease thereafter. So this is very, very important, and they are taking all markers like MI, stroke, CHF, cancer, dementia, and death, and very soon we will have a result. But the problem with metformin is it decreases the exercise capacity, and sometimes it can decrease VO2 max. So most consistent lifespan enhancer is acarbose, and how it modifies the lifespan? By modifying gut microbiota. And there are various trials which are available. The SGLT2 inhibitor, again, it is a calorie restrictor. By restricting calorie, it extends the life, and it has got pleiotropic effect, and various nutrient sensing pathway are involved in it, and because of this can retard aging. What about GLP-1? again same thing, anti-inflammatory, and it is acting on different organs. Do you know the trial of osteoarthritis is on with the liraglutide? Liraglutide being injected locally to treat osteoarthritis. Osteoarthritis independent of weight loss, they are assessing their action. Let's combine two agents together, the SGLT2 and GLP-1. You see, the purposeless immune response and maintenance overload can be taken care of if you are combining these two molecules. So this is very, very important. So only calorie restriction is not going to solve the problem. You have to have something which should retard the aging. The rapamycin is one. The multiple agents like rapamycin, acarbose, canagliflozin and estrogen mimicker can be given to prolong the age. So that is very, very important. I am not going in detail, but different molecules are there that can be upregulated once you are combining these agents together. Apart from this, all combination, there is important limitation. Last 2-3 slides, just last 2-3 slides, the limitation of anti-aging process. First thing, the hallmark of aging is less defined. It is not scored. The intervention is not scored. So if you are intervening, how you will assess the outcome? That is altogether a confusion, because of which right now we are not having any uniform guideline that is hampering the process. But very soon it will be available, and maybe a combination of biomarker with the scoring system may solve this problem. So this is one thing. So summarizing all these, there are positive therapeutics. What are they? They are aspirin, glycine and rapamycin and estrogen analog. The metformin is negative. The fish oil is negative. Statin is negative. Maybe because of the different reasons. So what are different key takeaway? First thing, age is an important risk factor for the chronic disease. The all hallmark of aging are affected by variability in aging. The nutrient sensing and epigenetic alteration, mitochondrial dysfunction are important event in aging. The senescence modifier are important therapeutic target. Gut microbiota, clotho, circadian disruption are important player in aging. The calorie restriction mimickers like SGLT2, metformin, acarbose are very, very important anti-aging agent along with aspirin. Statin I have not mentioned. The result of time trial, TAME trial, that will define how the aging study and research will go forward. The combination of agent is the solution along with the active lifestyle modification, along with the circadian rhythm and modification of gut microbiota, and at the end, the practicality should be there. मिश्रा जी ने इतने सारे ढेर सारे मैकेनिज्म बता दिए, कुछ तो निकला नहीं, ढेर सारे बात है, कुछ इसका मतलब तो आया नहीं. तो प्रैक्टिकलिटी क्या है? Pharmaceutical agents which are having very good safety profile, they are available for the longer period of time like 50 years. They have been used for longer period of time, should be evaluated for the anti-aging agent, particularly if they have anti-inflammatory property. First thing. The diet alteration is very, very important. Everybody is not allowed to eat how much they want. There should be calorie restriction and there should be time dependent eating, and intermittent fasting should be there with the low calorie diet and with the high calorie diet up to 1800 to 2000 and low calorie diet up to 800 in a normal healthy population to increase the aging. That is one thing. Physical exercise is very, very important, particularly if you are doing strength exercise and if you are doing evening exercise. That is very, very important, not a morning exercise. If you are having stress problem, then morning exercise is very, very important. Performing mental exercise is very, very important. Suppose somebody is retired and doing nothing, the senescence will take over and he will age faster. So mental exercise is important. The calculating index, the mini mental scoring, cognitive behavioral testing involved in a cognitive behavioral thing is very, very important. That's why it was told in the our ancient time that बुढ़े लोग बुद्धिमान होते हैं, उनका ओपिनियन लेना चाहिए, नहीं? तो and social engagement is also very, very important. Suppose somebody is isolated, then he will age fast. So in the beginning, what I was told, what I was saying, that attending a conference may retard your aging. Why? You will use your mind, you are refrained from your food, your exercise variability and heart variability will be checked. You are trying to catch a train, you are trying to catch a flight, you will have a social gathering and it will cause a happy environment. So please attend conference to enhance your aging. Thank you very much.
During this elaborate presentation, we are short of time and many things have to go. Thank you very much, sir.
Thank you, sir.
Thank you so much, sir. And we are running short of time, so may I request the other speaker in this session, Dr. Vinay Dhandania, sir, also to please join on the stage for felicitation ceremony. I request to chairpersons to first honor first speaker, Dr. Vinay Dhandania, sir. A big round of applause for Dr. Vinay Dhandania, sir. Come all the way from Ranchi. Our second speaker in this session, Dr. Ashutosh Mishra sir from Varanasi, delivered a wonderful thought-provoking talk.
But talk very.
Yeah. He has taught us how to stay young. Thank you so much, sir. And may I request the two speakers to please honor two chairpersons, Dr. Mahesh sir and Dr. Bharat Bhushan sir. A big round of applause for Dr. Mahesh sir. Round of applause for Dr. Bharat Bhushan sir, and Master of Mnemonics. And a bouquet for our Head of the Department of Medicine in Jawaharlal Nehru Medical College, Dr. Avinash Kumar sir. Thank you sir so much. Thank you so much, speakers and chairpersons. So the next, the final batsman of the day, or rather I would say most important talk, is the chairman's oration. It will be done by Dr. Hemshankar Sarma sir. And to chair this talk, may I request Professor Dr. Vinay Kumar sir to come on the dais.
Here, it's my responsibility to thank every one of you from this dais for your kind and gracious presence, without which the program would not have been a success. I'm thankful to all those who came here, participated in the scientific deliberations, participated in the floor discussions, and made the sessions lively. I'm thankful to all of them from the core of my heart, to all my postgraduate students and all other friends from different pharma companies as well, who came and made the program a lively one and a successful program. Thanks to the press and all that. And after this session is over, we will have a valedictory function, for which I will request that all those persons who have come from outside should also stay over here. Ajay Sinha, just listen to me. You have to stay over here for the valedictory function after this, right? You will be representing the RSSDI Patna component as an ex-chairman. Thank you. Over to chairperson. Now we can start the scientific session.
Dr. Hemshikar Sharma, our colleague from the Department of Medicine, Jawaharlal Nehru Medical College, a practicing physician, I should say a brilliant scholar, fluent speaker, faithful friend, and a team leader. You have just seen the whole scenario which is taking place since yesterday morning and which is going to conclude just now after his talk. Dr. Sharma will be speaking on imeclamin, a new drug for diabetes with new mechanism of action. May I now request Dr. Hemshikar Sharma to proceed. Dr. Hemshikar Sharma.
Thank you, Chairperson sir, for your nice comments and blessings. There are not many discussions over here about the aging, about the factors related to what was the cause in diabetes. There were many questions to Dr. Sujay Ghosh. Can you tell me one cause that what has led to diabetes? And the professorial answer was none. It is known that it is a multifactorial. It is not a disease basically. It is a change in the lifestyle of a person, of the individual concerned with different metabolic concerns. So taking into considerations and taking you back to 50 years ahead, when we had a very minimal number of drugs and all that, and all those drugs have been obsolete, except metformin, which has stood like a rock. And now the rock is also sinking. When we go by the researchers and all that, with the advent of the American Diabetic Association, I just recite a thing from Ramcharitmanas. Jehi giri charan dehi Hanumanta, chale suja patal turanta. While Hanumanji was flying over the sea and just went onto a hill for a small rest, and when he started the flight again, it went down. It was so forceful. So such is the force of the ADA, the European communities, that they guide us. The rest of the world is guided by, we are looking after the ADA recommendations always. And we are missing that what are the Indian recommendations? Where were we and where we are? And we are still having, I'm thankful to Dr. Mishra, who right now came with the aging and metformin. If the talk would have been aging and metformin just after Dr. Sujay Ghosh or Ajay Kumar, then that would have done wonders. So next time I will request some of the speakers to speak about metformin and aging. And that talk should be given just after the death burial of the metformin. Somebody speaking for that metformin is out of date, gone, and then there will be Ajay Kumar Sinha talking on metformin is the drug, which you can't say. It may be sleeping for some time, but it will come up again. In the search of all these aspects, a new drug is creeping into, and the drug is imeclamin. A new drug for diabetes with new mechanism of action. Ultimately, what everyone leads to where we look into, where we go, beta cell functions. So what is inside the beta cells? Mitochondria. And we go into the mitochondrial components, that we are going into the bottom to strike that what is the basic mechanisms, why and how it is helping through these mitochondrial inventions. How the drug was investigated? It was first in class novel oral agent for the treatment of type 2 diabetes mellitus. Inclements is the first in a new tetrahydrotriazine containing class of oral anti-diabetic agents referred to as Glimins. Its discovery was enabled by in vivo. Everything goes in vivo then in vitro. It goes like this, it tilts from this side to that side. And similarly, how it has come into picture. While we just go into the different slides and we will be finding out, I will just take you back to what happened to teneligliptin. You remember when teneligliptin came from the Japanese market, it was accepted by very few countries, the Koreans and the Indians. We took over, considering that it was a very cheap drug. And it was a comparable drug. And what were the different stalwarts all over India, they were roaming around, to name a few, like Dr. Jay Kumar or Dr. Avdesh Singh or Dr. Sujay Ghosh or anyone. No. Teneligliptin is not recommended, no US FDA approval and all that. That was the basic. And what happened in the market community? Everyone accepted teneligliptin because it was a very cheap drug and almost having a efficiency match to match, not exactly surpassing or not very good drug. I will say, you just compare that with linagliptin and all that, with the different trials it went down, but it is still in the market and it is not going to go away from the Indian markets. So these are the issues. And Ajay Kumar in one of his talk, he confessed over here, 19-20 का अंतर है भाई. माना कि टेनेलिग्लिप्टिन 19 है, दवाई में तो 19 नहीं 17 हो जाता है. जब उसकी कीमत पर आते हैं तो गरीब आदमी के लिए ये ग्लिप्टिन में तो टेनेलिग्लिप्टिन दिखता है, दूसरा तो कोई दिखता नहीं. ये बात आज भी चर्चा में थी. और now what we come to, we were all talking of insulin resistance, insulin sensitivity, and through beta cells, reversal of the beta cells activities, reversal of the diabetes, which is a misnomer to me. You cannot revert this disease. You can just go on fighting and have a floor discussion on the academics like this. In one of the CMEs, there will be a fight between the speaker, the chairpersons, and the audience. All the three fighting together. Is it a myth? Is it a reality? Nobody can change it. Can you change the aging? You can't. You can only delay the aging. Can you change a person who is suffering from nephropathy and diabetes after 10 years of standing diabetes? You can't. There has to be a microvascular complication. You cannot stop it. You cannot stop it. But what you can do, that you can delay, you can alter, you can improve the lifestyle and quality of life. These many things and multifactorial aspects you can consider. All these aspects. Going back into what I am going to talk right now, immunoglobulin, as described in this review, the mode of action is unique and distinct compared with other major classes of therapeutic agents. It involves the dual effects both to enhance insulin action and reverse pancreatic beta cell dysfunction. Through what? A genetic predisposition. What diabetes is, what I had started talking well before I went into my slides. It is genetic predispositions plus affected by many factors. The key environmental factors, principally overnutrition and reduced energy expenditure, are drivers of the disease. ज़्यादा खाओ, मस्त रहो, कोई काम मत करो, कोढ़ी हो जाओ. And you invite these problems, all such problems you will be inviting. Consequently, defects in insulin action plus pancreatic islet beta cell dysfunction, leading to a glucose intolerance and the reflections of the typical factors and the complications of the diabetes mellitus. Subsequently, the onset of the overt diabetes. Insulin resistance occurs in several tissues, including skeletal muscles and in the liver, where the effect of insulin to suppress glucose production is आवाज देखो, इतनी तेज आवाज तो मेरी नहीं है कि तुम्हारी आवाज बंद हो जाएगी. Now, a deficient beta cell function is evident from a marked reduction in the acute insulin secretory response to glucose, both in vivo and in islets isolated from patients, and the partial loss of the response to other stimuli, including glucagon-like peptide 1. A clear loss of beta cell mass has also been documented in the humans with type 2 diabetes mellitus. So, at the molecular level, what happens? The mitochondrial dysfunction is a prominent feature of type 2 diabetes mellitus pathologies that contribute to both beta cell defects and the insulin resistance. The importance of the mitochondrial function is underscored by the existence of rare inherited forms of the type 2 diabetes that results from mutations in mitochondrial DNA. We have almost put this into back pictures. We are always discussing the other aspects and not going into the details of the mitochondrial level involvements of the insulin secretions or the beta cell dysfunctions. So mitochondrial dysfunction is manifested in several ways: by deficient oxidative metabolism, reduced ATP generation in several tissues, along with more specific defects, or incomplete fatty acid oxidation leading to a cellular lipid metabolic changes, accumulations of the lipids in various tissues, reduced mitochondrial content and structure damage. So everything revolves around the mitochondrial components and the mitochondrial exchanges, take up of the factors and the different ATP mechanisms which are helping through the mitochondria. Defects in mitochondrial respiratory chain also causes what? Excessive reactive oxygen species formation leading to type 2 diabetes mellitus pathophysiology. So this should not be undermined. So all the pathology of this, the microvascular and thereupon that revolves around the mitochondria, that is our cell of respiration. Our life revolves around that only. And once we talk anything you talk about, it revolves around that, because if you can't breathe, the breather is mitochondria, cell. Nicotinamide adenosine dinucleotide is a critical cofactor that is required for mitochondrial functions and several other core cellular functions including cell survivals. Importantly, metabolic disorders including obesity and type 2 diabetes mellitus are associated with altered NAD metabolism and generally reduced levels. Moreover, exogenous nicotinamide and NAD precursor have been shown to augment islet beta cell functions. Imiglobin's dual mechanism of action may result from more specific effects that target the molecular aspects of the diabetes pathophysiology. Reversal of beta cell dysfunction via amplification of the glucose stimulated insulin secretions, GSIS, and augmentation and insulin action in liver and skeletal muscles. These are our targets. We were discussing about the metformin. It doesn't affect the skeletal. Friends, for this valedictory function, it is our esteemed duty to thank each one of you who has participated in the program and made it a grand success. The assessment that whether it was a success or not, that depends upon you. And unless you say your words, it is difficult. We have done our job. I have done it with my team. And with my team of two discoveries, I will say, one was an older discovery, re-strengthened Dr. Ubaid Ali, and another is Dr. Kamran Khan. Kamran has been a man, yes, he needs applause. He is a person, he was just sleeping in his kutir. And I picked him that Brahmachari jana utho. Or sannyasi kutir se niklo. He was in a slumber. I picked him up and pushed him. And my all friends over here, they said कि तुम जिस लड़के को पकड़े हो क्या करेगा? हमने कहा कि जब जगेगा ना तो क्या करेगा वो देखना. और आज आप जो देख रहे हैं, इसके मेजर कंट्रीब्यूशन में एक बड़ा कंट्रीब्यूशन इस लड़के का भी है. I am happy he has been my student, and I am lucky to have many students. Even Dr. Ajay is here. तो आप समझ सकते हैं उतना बड़ा स्टेचर का मेरा स्टूडेंट है, तो हमारा स्टेचर छोटा तो है, आप घबराइए नहीं. Now for this valedictory, I just ask as the representations, the Chairman Reception Committee, Professor D.P. Singh, to take a seat in front. Dr. Kamran will be conducting the sessions, and two representatives, one from the state headquarters, Dr. Ajay, the past chairman, and Dr. Supriyo Mukherjee in the current team. Supriyo, please take a seat over here. And now, Ubaid, yes, this is the person, the giant has come. अरे तालियों में कमी है यार, मेरा जोर से, मेरा उबैद बहुत थक गया था अभी, मेरे साथ एक जजमेंट के चक्कर में घूमते घूमते गर्मी में बाहर परेशान था, and then he felt little down. He said कि सर मैं जरा सा मुंह हाथ धो के आता हूँ, और उस तकलीफ के बावजूद वो गया और वो तुरंत लौटकर यहाँ वापस आ गया. So I am thankful to Ubaid also, Okay. So he has also endorsed his younger brother Kamran Khan to do all these honors. And a person with the activity of whom you are seeing all these since yesterday is no less than a man, Manish Kumar. Manish, a good applause. And Manish has been the backbone of all the scientific activity since decades, not years, since decades. He has run the show, and I think on 2 occasions the scientific chairman was Professor Vinay Kumar. Previously also, and this is the team which has done wonders. Kamran has done, he was present everywhere. He was in scientific, he was in खंबा गाड़ो, ये सजाओ, वो सजाओ, रात में नींद नहीं आ रही है, तूफान आया तो इसके दिल में तूफान आ गया, इसके दिमाग में तूफान उड़ने लगा, कहा सर सो नहीं सके रात भर वो और उबैद को नींद नहीं आई, सुबह सपना देखा उबैद ने कि ऐसे ऐसे करना चाहिए। बहुत चीजों की बातें हुई और आपने देखा कि कल उस उजड़े चमन को बहार में बदलने के लिए लोगों ने कितनी मेहनत की। और मैं उस लड़के का धन्यवाद दूंगा, आनंद मिश्रा। खड़े हो जाओ, किधर हो, ये सामने आ जाओ बेटा। जिस लड़के पे इसने भरोसा किया था, हम लोगों ने कहा कहां से किसको पकड़ के ले आया है यार, समझ में नहीं आता है क्या करेगा, लेकिन जो उसने किया कल वो तो जबरदस्त था। Here is one boy who also deserves to be thanked and clapped. Now, अब मैं इसके पहले की बाकी काम करूं, मैं रिक्वेस्ट करूंगा कामरान से कि वो कुछ करें।
Thank you, Chairman Saab, and it's really a pleasure to end such a beautiful conference in this way, that everybody is happy and everybody is going with a smile and a positive vibe. So I would like to thank many people today in this event, because due to them we have achieved this feast of knowledge, and in accordance of the events and in calling different people according to their job and their involvement, their dedication, I would like to also say here that many of our faculties and delegates who have not received the mementos will also receive mementos. So first I will call the names of those people who have not received mementos yet, and I will call Dr. Hemshankar Sir, Chairman RSSDI, to honor them with mementos. Dr. Ajay Singh. Dr. Ajay Singh, our Secretary for Travel and Hospitality. Dr. Anand Sinha, our Secretary for Cultural Events. It was his effort that you saw last night how the events took place and enchanted everyone. Everyone was thrilled by the event. Beautiful cultural event, and a big applause for him. Dr. Anand Sinha. Dr. Anand Sinha. And a lion comes. Many congratulations, Dr. Anand, for being part of our cultural team. And here a lion comes who was announcing awards and all the bouquets and everything for other people. Today I am calling Dr. Manish, our scientific secretary, to receive his memento from Dr. Hemshankar Sir.
I cannot invite our own secret. मनीष और साइंटिफिक सेशन दोनों सिनेमा मेंबर्स हैं. जब भी साइंटिफिक प्रोग्राम होता है, मनीष ना रहे तो लगता ही नहीं कि साइंटिफिक प्रोग्राम होता है. And I invite Dr. Obaid Ali to receive his memento, which was due. It is a formality rather, because he cannot be rewarded by anything for his efforts. So I'd like cheers for Dr. Obaid Ali, our secretary, organizing secretary. Yeah, standing ovation for him. Standing ovation for Dr. Obaid Ali. He has emerged as a giant killer.
सबका ले लीजिए फोटो उधर जो स्टैंडिंग
Now I call the people who were very much, who were involved day and night with their all efforts and mights to make this conference successful. And I would like to call those people here to, I will felicitate them with honor. And in this regard, I would like to call Mr. Anand Mishra, first of Jalaram Events, to receive a I would like to invite reception chairman Professor Dr. D.P. Singh sir to share dice with M. Shankar sir in awarding different people, and Dr. Ajay Sinha sir. So big applause for Jalaram Events, Anand Mishra. Very big applause.
गर्म हो रहा है.
Now I'd like to call on stage Mr. Razak Ali, the So I would like to invite Mr. Raza Kalim brothers, who performed a very artistic presentation in terms of various standees and flexes and decoration of halls and our cosmetic outlay. They planned very well and they created each and everything of all the stationeries, leaflets, banners, posters, and they deserve a felicitation from her. And now I would like to call a person who has shown such a dedication in last 3 to 4 days, although he is involved for the last 1 week, and he has shown. Mr. Neeraj, please come for your utmost dedication. From MAT, Mr. Neeraj, who welcome each and every guest at airport, at stations, and make them check in to the hotels. And he called each and everyone regarding their stay, their wellness. Really, he did a wonderful job. I would like to call Mr. Tathagat also here.
नीरज ने हमारा वो काम किया है जो हम शायद सपने में भी नहीं कर सकते थे। हमारे एक एक गेस्ट के एक हफ्ता पहले से उनका ट्रैक लेना, कब आ रहे हैं सर, कैसे आ रहे हैं, कहाँ आ रहे हैं, उनका ख्याल रखना। 24 घंटा ये बंदा होटल में कल से सुबह से लेके आज सुबह तक बैठा हुआ है। जो आ रहे हैं उनको रिसीव करना, जो जा रहे हैं उनको सी ऑफ करना। मेरा इतना डेडिकेशन किसी और को नहीं देखा है। थैंक यू। मेरे पास सारे स्पीकर्स के स्क्रीनशॉट है जो उन्होंने भेजा है। ये बंदा लड़का कहाँ कैसा है, एक मैंने तारीफ के पुल बांध दिए सारे हमारे गेस्ट जो है स्पीकर्स। थैंक यू वेरी मच।
I would like to invite Professor Dr. D.P. Singh, if he is, and Madam also here, for continuous efforts put by him. Please, ma'am, please come on the stage, along with sir. On the day of 1st of April, Dr. D.P. Singh called me at 5 a.m. that don't be panicked, trust in your ability and start afresh. So this support cannot be forgotten, and this guidance cannot be forgotten. And I would love to see sir guiding us for many more years to come and in many more events like this only. He is really a father figure for us, and definitely he has guided us to the combination. Thank you, sir. Thank you, sir. Now I would like to invite Dr. Mahesh here on the stage. He is consistently present in this scientific session. He is chairing the session also, and he has contributed a lot towards our scientific sessions. So please come, Dr. Mahesh, sir. And now I would like to invite Ma'am Dr. Himchandra Sharma and Varsha Madam to be here, because these two powerful ladies have also contributed a lot in making this conference a great success, directly or indirectly. And certainly I would like to have Dr. D.P. Singh sir, please felicitate them with your own hand, and Dr. Ajay also, you come. These two powerful ladies who perform their duties outrageously. Ma'am. Thank you, ma'am. Thank you for
सर पास में हो जाइए। अब मैडम बोल चलिए। आप बीच में मेन टाइम
Thank you. Now I would like to call Mr. Zija Hussain, who performed a very great job in creating the media and all the people aware about the event, and he must be truly rewarded for that, and big applause for him because he was liaising with the media people, and definitely all the media houses got coverage of this our conference. So thank you, Mr. Zija Hussain, for your contribution. I'd like to call Mr. K.K. Raju of Mithas Tours and Travels. So please come forward for making the things smooth for us in initial tough days. So Mr. K.K. Raju. Now here comes our OSD officer on a special duty, which I have coined a word for him because he was performing like this. Mr. Vishwajit Chaudhary, a big applause for him. And Mr. Roshan Sinha, you also come here. 1 and 2, his deputy Roshan Sinha, and both of them were working like a jinn in performing. So big hand for Vishwajit and Roshan. I'd like to call Tathagat, Mr. Jitendra from Daxil, and Prabhakar to come here on the stage to receive felicitation for their work, their relentless involvement in this event, and certainly they have played a very good role in their own capacity and beyond their capacity, I would like to say, and they deserve a big applause. Mr. Tathagat, Prabhakar and Jitendra. I would like to call Professor Dr. Vilesh Kumar, Dr. Rajkamal sir and Dr. Bharat Bhushan sir to come on the stage so that Angavas can be, we can honor them with Angavas. And Professor Dr. D.P. Singh, I would like to request you to please honor them with Angavastra. Dr. Bharat Bhushan, Dr. Abhilesh sir and Dr. Rajkamal Chaudhary sir. फिर से एक बार.
These are the 3 permanent chairmen.
Yeah.
Permanent chairperson. Thank you very much.
Thank you. Thank you, sir.
Would be professor of the district. Dr. Raj
Now, from the pharmaceutical Dr. Vinay sir, Professor Vinay Kumar sir, please come to the stage and accompany all the professors here, your juniors, and yeah sir. Yeah, sir. Thank you, sir. Thank you, sir. Yes, sir. Thank you, sir. Thank you, sir. We have pharmaceutical stalls here, and definitely all the people, all the companies participated with full enthusiasm, and they tried their best to attract delegates. But we have chosen three companies, and we are going to call them on the stage. Mr. Hemant from SR Medicare, please be on the stage. And if somebody is there from Aristo, please come to the stage. And from and managers from Aristo also. So yeah, if somebody is there from Alchem, please come, Alchem people. Mr. Hemant from SR Medicare team, please come.
Actually, all persons have helped us. I am thankful to each one of them जिन्होंने हमारी मदद की है और हमारे साथ खड़े रहे थ्रू आउट द कॉन्फ्रेंस. उनके बिना ये कॉन्फ्रेंस सक्सेसफुल नहीं हो सकता था. हम लोगों ने अपने में तय किया था कि हम लोग विजिट करेंगे स्टॉल्स को, और जो 3 स्टॉल हमें सबसे अच्छे लगे और डिफरेंट ग्राउंड्स हम लोगों ने मार्क्स उसमें अलॉट किया हुआ था, वो डिस्कशन हम नहीं आपसे करेंगे. लेकिन फर्स्ट प्राइज के रूप में हम लोगों ने जो एसआर है उसके हेमंत जी को दिया. सेकेंड इज को, थर्ड इज के. ये फर्स्ट सेकेंड थर्ड से फर्क नहीं पड़ना चाहिए आप लोगों के बीच में, लेकिन आप तीनों ने लगभग एक जैसा परफॉर्म किया. थोड़ा बहुत ऊपर नीचे का फर्क पड़ रहा था, तो मार्क्स में कभी कभी कोई लड़का फर्स्ट, कोई थोड़ा सा फर्स्ट से नीचे होता है, और कोई बात नहीं है इस पर. ऑल द 3 आई रिक्वेस्ट आपके तीनों लोगों के रिप्रेजेंटेटिव, अल्केम के रिप्रेजेंटेटिव को आइए, 2 जने आ जाइए ऊपर में, अगर बाकी लोग आप नहीं. हाँ, तो ऑल दी 3 आर द लीडिंग ब्रांड्स लीडर्स as far as these are concerned. But I tell you that every one of you have done your job. हमेशा चीटी जो काम करती है वो सब मिलके करती है, और हम लोग सब दुनिया में चीटियां हैं. हम लोग सब मिलके काम करते हैं, मिलके छत्ता बनाते हैं, मिलके घर बनाते हैं, और मिलके पहाड़ खड़ा करते हैं, और उस पहाड़ पर से मुस्कुराते हैं, एक दूसरे की तालियां बजाते हैं. थैंक यू ऑल फ्रेंड्स, थैंक यू ऑल वेरी मच. Small token we are giving this.
Mr. Hemant sir.
Respected all seniors and my colleagues. बिल्कुल उन्होंने जैसा कि बिल्कुल कहा वो हमारे सब लोगों को रिप्रेजेंट किया एग्जैक्टली नेचुरल कैलामिटी के बाद भी जिस तरीके से आपने आउटकम दिया हम सब सबके सहयोग के साथ किए। मैं यही प्रॉमिस करता हूँ कि जो आपने लैंडमार्क किया उसमें हम लोगों की तरफ से जितना सहयोग हुआ है ये सहयोग हमेशा कायम रहेगा इन्हीं शब्दों के साथ।
2% they need special thanks, special mention. एक जिसने आने जाने वालों की हर हरकतों पे नजर रखी, आने के लिए वेलकम किया और वो उन चंद लोगों में थे या वो शायद उन 2 शख्सियत में थे जिन्होंने सबसे पहले कहा कि सर मैं तैयार हूँ आपका कॉन्फ्रेंस करने के लिए, आप मुझे पूरा कॉन्फ्रेंस भी दे सकते हैं। मैंने कहा नहीं भाई ऐसा जुलूम मत करो, सबको साथ चलने दो, सबका साथ सबका विकास करो। और मैं उस शख्सियत को दिल से धन्यवाद देना चाहूंगा। एज ए रिप्रेजेंटेटिव ऑफ द ऑर्गेनाइजिंग कमेटी मिस्टर मिथिलेश मिश्रा, प्लीज यू आर वेलकम ऑन द स्टेज। आप आए, आपने बहुत बड़ा काम हमारा किया है और सबसे अच्छी बात थी कि कल उन्होंने उबैद जी से ये पूछा कि सर मैं और क्या कर सकता हूँ आपके लिए, आप बताएंगे और अगर कुछ भी कमी आपको लगे, कहीं भी आपको लगे कि आप परेशान हो तो आप मुझे बोलिए। और ही इज इवन रेडी टू हेल्प एनी मोमेंट। सो ये तो उसका ग्रेटनेस है। थैंक यू मिथिलेश। मैं चाहूंगा कि उबैद, कामरान दोनों, डॉक्टर डीपी सिंह, अजय, सब लोग मिलके उसको चादर, ये तो एक छोटा सा हम लोग की तरफ से भेंट है। हाँ बिल्कुल टीम आ जाए, कोई दिक्कत नहीं है, आप अपनी टीम को बुला सकते हैं। और मैंने कहा कि 2 आदमी, तो दूसरा जो मेरे दाहिने तरफ टीम बैठी हुई है ऑडियो विजुअल का, लगातार जिसने एक वाक्य पर हमारे पूरा समय दिया, सब कुछ किया और करते आ रहे हैं। पिछले जब से हमने कॉन्फ्रेंस यहाँ शुरू किया है, जितना भी राज्य स्तरीय कॉन्फ्रेंस किया, सब में हमारे द्रवेश झा जी खड़े रहते हैं। इफ द्रवेश इज हियर, उनके रिप्रेजेंटेटिव हैं, छोटा भाई आ जाओ भाई। ये कोई भी कॉन्फ्रेंस हो, और इतना ही नहीं, इनका कमिटमेंट देखिए सर, आप जितना कॉन्फ्रेंस जब भी करेंगे, अगले जितने साल में भी करेंगे, साल में 5 भी करेंगे तो मैं करूंगा। प्लीज यू आर वेलकम, मोस्ट वेलकम, आई एम थैंकफुल टू यू। और मैं चाहूंगा मेरे साथ डॉक्टर डीपी सिंह सर दोनों, इनको सम्मानित।
सबसे बड़ी खूबी है अपने आगे आना नहीं चाहता, they will never say कि मैं हमको खींचना, अपना चेहरा नहीं दिखाना चाहता, but so dedicated to our whatever that job is.
Representative of Women's Wing की, I think Mrs. Supriya Mukherjee, सुष्मिता मुखर्जी, अच्छा मिसेस सुष्मिता मुखर्जी, प्लीज डॉक्टर, हाँ तो डॉक्टर सुष्मिता मुखर्जी, प्लीज बी ओवर हियर। यू विल बी ऑनर्ड बाय द एबल रिप्रेजेंटेटिव फ्रॉम माय टीम, डॉक्टर सुप्रिया मुखर्जी। And I will request the old friend and chela, Dr. Ajay Sinha, to please come over here and witness. अब देखो कि सुप्रिया भागे नहीं इधर पर। अजय has also come. Thank you ma'am, thank you so much. May I now
request the ever smiling woman of my team, Dr. Archana Sinha, if she is here, please do come on the stage. आपने बहुत बड़ा काम किया है और आपने पूरा कंट्रोल किया कल वर्षा के साथ कंधे से कंधा मिला के, और इतना ही नहीं, इसके पहले भी आपने कई दिनों से हम लोग का साथ दिया है। और आप, मुझे अभी भी याद है वो कुछ मनीष ने बताया था, बाद में बोलेंगे। नाउ मे आई रिक्वेस्ट वर्षा टू प्लीज कम एंड ऑनर अर्चना। ये देख के अच्छा लगा, कल स्टेज पे हमने नहीं कराया जानबूझ के ऐसा। थैंक यू अर्चना, थैंक यू वेरी मच, यू हैव ऑलवेज बीन विद अस, थैंक यू। रॉली, इफ शी इज हियर? नहीं सर। नो, तो मैं रॉली का नाम लेना चाहूँगा। आनंद जी उन तक बात पहुँचाएंगे, उन्होंने बड़ी हमारी मदद की, बहुत अच्छा लगा। और ऑनर में हम लोग उनको नेक्स्ट मीटिंग में कर देंगे, क्योंकि आपको चादर देने से मुझे डर लगता है कि पता नहीं आप रॉली को पहनाएंगे कि नहीं पहनाएंगे। इसलिए वहां भी वर्षा ही देंगे उनको, लेकिन अगली मीटिंग में देंगे। एक आदमी जिसका नाम मैं लेना चाहूंगा, जो इत्तेफाक से यहाँ पर शायद अभी दिख नहीं रहे हैं, नहीं, अंजुम परवेज। अंजुम ने हमेशा बहुत ही सबको इवेलुएट किया है और बहुत बढ़िया बढ़िया बातें बताई है। हम लोग जब मंच बना चुके थे, स्टेज के सामने में हम लोगों ने पूरा थोड़ा कवर कर दिया था हिस्सा, तो इट वाज बेसिकली अंजुम परवेज हु केम, और उसको मैंने कहा कि अंजुम जरा देखो तो उबैद को थोड़ी मदद करो, तो ले गया उबैद को पकड़ के, कामरान को पकड़ के ले गया, मुझे भी ले गया, हिमदा जरा देखिए ऑब्स्ट्रक्शन हो रहा है। तो हम लोग का दिल तो नहीं माना, मैंने कहा कि इतनी मेहनत से बनाए लोगों ने बड़ा बड़ा चौड़ा सा स्टेज, हमने कहा इसको पतला करके बांस का कर दो, लेकिन अंजुम ने कहा कि नहीं सर, इसको हटा देना बेहतर होगा। और ये सपना मैंने बताया था आपको कि उबैद को भी आया था रात में कि उसको हटा ही देना है, एकदम ध्वस्त कर देना है। सुबह सुबह ऑर्डर हुआ आनंद को कि हटाओ इसको, मैं देखना नहीं चाहता हूँ। और कल आपने देखा कि वो जो मेगा शो था, वो जब हम लोगों ने मंच के सामने में खुले आकाश में किया और ऊपर भगवान ने हम लोग का साथ दिया, बारिश नहीं हुई, तो लगा मुझे कि मैं एपीकॉन से आगे हूँ। और पिछला एपीकॉन हमने अभी किया था गुजरात में, अहमदाबाद में, बहुत सारे फार्मा वाले भी लोग वहाँ होंगे। मैं चर्चा नहीं करूंगा कि वहाँ उनका क्या परफॉर्मेंस था, लेकिन मैं उनसे ही गुजारिश करूंगा और उन लोगों से जिन लोगों ने पार्टिसिपेट किया था अहमदाबाद में, तो वो तय कर लें कि एपीकॉन गुजरात में अहमदाबाद की बड़ी छत्र छाया में करोड़ों की लागत से जो हुआ, और जो हमारा ये छोटा सा घर था कुटिया वाला, इसमें क्या अंतर था, क्या समानताएं थी, और हम कहाँ थे, वो कहाँ थे, ये आपका खुद का आकलन होगा। मैं कोई चर्चा नहीं करूंगा इस पर। मित्रों, सब बातों के बाद मैं पुनः एक बार सबको धन्यवाद दूंगा। आई एम जस्ट वेटिंग फॉर द रिजल्ट्स ऑफ माय पोस्ट ग्रेजुएट स्टूडेंट्स। कल उन लोगों ने बहुत ही अच्छा परफॉर्म किया था। आज फॉर्चुनेटली या अनफॉर्चुनेटली मेरे लिए, आज मैं इधर बिजी हो गया टॉक वॉक के चक्कर में और कुछ बातों में, तो आज मैं उनका पोस्टर प्रेजेंटेशन नहीं देख सका, लेकिन हमारे मित्र वहाँ लगे हुए हैं, आनंद शंकर और पीवी मिश्रा जी आए किधर, अभिनय ढंडनिया को बुलाओ। हाँ, ये अभी अगर जस्ट मैं एक आध मिनट वेट कर रहा हूँ, रिजल्ट लगभग तैयार हो रहा है, साइन वाइन कुछ हो रहा है। जिन पीजी स्टूडेंट्स को सर्टिफिकेट सिग्नेचर वाला नहीं मिला है, कल के लिए भी वो मिल जाएगा, इस प्रेजेंटेशन का भी मिलेगा, किसी को कोई दिक्कत नहीं होगी, इसलिए कोई परेशान मत होना, डिपार्टमेंट में मिल जाएगा सबको, कोई घबराने की बात नहीं है, हम लोग सब साथ हैं। और राजकमल जी को ड्यूटी इंटरेस्ट की हुई है कि सारे लोगों को सर्टिफिकेट मिल जाए। इसके पहले कि हम अभी और एक गेस्ट का इंतजार कर रहे हैं, वीरेन ढंडनिया जी का। मैं चाहूंगा कि हमारे चेयरमैन रिसेप्शन कमेटी डॉक्टर डीपी सिंह साहब ने कल सबको वेलकम किया था, उसके पहले मैं इनवाइट करूंगा डॉक्टर अजय सिन्हा को, भागलपुर से जुड़े हुए हैं, वर्षों यहाँ गुजारा है, पढ़ाई लिखाई दरभंगा में हुई, मैंने उनका पीछा किया दरभंगा तक, उसके बाद भी वो मेरे साथ ही हैं, बने हुए हैं डिफरेंट प्लेसेस में, अलग अलग जगहों में। ढेरों आशीर्वाद उनको है। मैं चाहूंगा कि वो एड्रेस करें यहाँ से।
Thank you, sir. Distinguished guests from outside Bhagalpur, the senior professors, the faculty of the medical college, consultant of the town, trainee students, pharmaceutical people, people from pharmacy, media people. It was a wonderful conference, I must admit. I am going with a positive vibe. I have enriched my knowledge, I have refreshed my knowledge, and I have become more wiser after the completion of 2-day conference. So thanks to organizing team, the RSSDI BIHAR, Bhagalpur. They have done a wonderful job. And the evening program was matching with the annual conference of the India. So that was we all enjoyed. और जैसा हम शंकर दा ने कहा कि yes, he was my near peer mentor. जब मेडिकल कॉलेज में दरभंगा में आप जानते हैं कि मेडिकल स्टूडेंट्स और जो पीजी होते हैं उनका रिलेशन बड़ा स्ट्रांग होता है, और उसमें डॉक्टर हेमशंकर शर्मा एक्सलेंट थे, तो हम लोग इनके पीछे पीछे भागते थे. सो ही वॉज अ वंडरफुल. और आई एडमिट कि जो हमने खनकीता चौक से शुरू किया अपना करियर बहुत ब्रीफ था, एंड टुडे आई एम वर्किंग एट, तो इस बिटवीन मैंने अपना जो मेडिसिन का जो नॉलेज और क्लिनिकल प्रैक्टिस का सेपिंग एंड रीसेपिंग किया, उसमें ज़रूर मैं मानता हूँ कि हमारे नियर पियर मेंटोर जो डॉक्टर हेमशंकर शर्मा थे वो एक्सेलेंट थे. सो आई ओwe माई ग्रेटिट्यूड टू डॉक्टर प्रोफेसर हेमशंकर शर्मा सर. एंड the arrangement of conference is not easy. I have done it many times. It is difficult, but it seems to me very satisfying that the conference, every month there is some conference, but this conference has made a benchmark, or I am sure that the benchmark can be broken only by the Bhagalpur people itself. That is going to happen. So thank you, sir. You have given me an opportunity, and thank you all the pharmaceutical people those who have been sponsored and those who are behind this scientific conference. So I know many of the Kasip is there, the Javed, Mr. Javed, and many other Delhi people, Sridot people. So I thank all the pharmaceutical people from my side. Thank you once again, all the seniors. My regards.
Thank you, Ajay. Chela has made me proud. मुश्किल होती है कभी कभी. If you become sentimental, then it is a player problem. Another friend of mine, close to my heart, who has all the way come from Ranchi, Dr. Vinay Dhandania. He is a very good photographer and a far excellent diabetologist in the national conference itself. So may I ask you your experiences about us? We are small chaps over here. We are very new in this field. So you are a great man.
Thank you very much. As a small chapter, Jharkhand or Bihar, I need not say anything on that. But I definitely congratulate each and every member of this team, organizing team, for a wonderful conference. And it's a real clinical conference for everyone to learn in day-to-day practice. That is what is very, very important. We as a clinician are less inclined towards research, but more inclined towards our patient care. And this
रहेंगे एक नंबर पे रहेंगे. मैं तो भी चाहूँगा कि आनंद जितना भी समझ सकता है और यहाँ से बताएंगे वो कि किसने क्या किया है. अगर कोई भी आदमी कुछ भी यहाँ से बोलना चाहे फंक्शन से रिलेटेड, मैं एक आदमी को किसी को मौका दूंगा जरूर बोलने के लिए. If any one of you from any field, any faculty, इसके बाद हम लोग समाप्त कर रहे हैं. And I am going to invite you for the lunch, which is almost ready over there. Lunch is ready. Lunch is ready. Yes, yes. It is already ready. Just I am waiting for the results. Thank you, Ajay. Thank you very much. Thank you, Ajay. You are done? Or if the result takes a little bit of time, then okay, go. Dr. Supriyo, please you also join. You are the academic man of the RSSDI. So this is an academic performance. And second is in the talk is Dr. Kundan from Bhagalpur. Kundan, yes. Congratulations. आप लोग तीनों रुकेंगे. Poster presentations, I told you that it was a difficult job for the Professor Anand Shankar, who was at a loss. Sir, it was really difficult, and the results will tell you that it was really difficult. We have two joint PG first. Dr. Kundan PG first year, Dr. Kundan PG second year. हमें लगता है कि आनंद को कुंदन भाग है, क्योंकि आनंद अपने आप में ही कुंदन है. कुंदन का मतलब सोना होता है. आप लोग आ जाओ. Kundan 1 and Kundan 2. You will be honored by the professors of our college and the research representative, Dr. Supriyo, who is a class apart. Once you listen to him and the accent of the English vocabulary, what we have learned from him is really marvelous. And again the problem for the second prize as well. Again there is a joint second prize. Dr. Devajit and Dr. Vinay Kumar PG 2. Dr. Vinay Kumar PG second year. Two joint. मेरी समझ में नहीं आ रहा है. आनंद ने कहा कि ये जॉइंट है, सर ये लोग जाइंट्स हैं. तो मैं क्या बोलूं सर, अब बोल नहीं पा रहा हूँ. बहुत मुश्किल हो गया. वह एक एग्जामिनर को मेरा बेचारा डर से भाग गया कि हम नहीं रहेंगे सर. टेंशन हो गया उसको. वो चला गया रिजल्ट्स के डर से. तो आनंद इज सीजन गाइड. डॉक्टर देवजीत and Vinay Kumar, I congratulate you both. You have done very good. And the third prize goes to Dr. Umesh Kumar Mishra, PG second year. Umesh Kumar Mishra. And my special thanks to Dr. Anand, and I will invite him to my. Hello. May I request Dr. Anand Sinha to please come over here. Sir, I request all three of you to present to Anand Sinha a token of gratitude presented to Professor Dr. Hemant Kumar Sinha. So he will be handing it over to him. I will just request Anand Shankar to say a few words. मैं जानता हूँ बोलने में तुम थोड़ा टॉक के अलावा बाकी जगह कंफ्यूज हो जाते हो, क्योंकि तुम्हारी आंखें ज़्यादा चलती हैं कैमरे के पीछे से, है ना? तुम चिड़ियों को ज़्यादा पकड़ते हो. Please do come over here and just address about the performance of my students. You have seen their performance and just.
Thank you, sir. Dear PGs, आप लोग बहुत अच्छा किए और मेरे क्वेश्चंस बड़े अनयूजुअल थे. मुझे पता है कि मेरे क्वेश्चंस आउट ऑफ कोर्स थे. आउट ऑफ कोर्स इसलिए थे कि आप लोग स्टिमुलेट होइए कि आप लोग सिर्फ कोर्स नहीं पढ़े, कोर्स के बाहर भी पढ़े. 2 पोस्टर ऐसा था जो कि केवल मेडिसिन नहीं है, वो आर्ट्स भी था. तो जब तक आप पूरा नहीं पढ़िएगा वो पोस्टर आप समझ नहीं पाइएगा। आपने पोस्टर अच्छा बनाया, सारे लोगों ने बहुत अच्छा पोस्टर बनाया। ध्यान रखिए कि उसमें रेफरेंस जरूर मेंशन कीजिए। पोस्टर विदाउट रेफरेंस उसका वैल्यू कम हो जाता है। रेफरेंस जरूर होना चाहिए। एम और ऑब्जेक्टिव क्लियर होना चाहिए। तो आई कॉन्ग्रेचुलेट ऑल ऑफ यू, ईच आर विनर। डोंट से कि फर्स्ट सेकंड थर्ड, ये तो पार्ट एंड पार्सल ऑफ कॉन्फ्रेंस और प्रोफेशनल लाइफ है, इससे नहीं होगा। लेकिन आप लोग बहुत अच्छा मेहनत किए। थैंक यू ऑल एंड कॉन्ग्रेचुलेशन।
I am personally thankful to all those my cameramen who have worked day in and out. हर जगह काम किया है आपने, यहाँ बाहर चारों तरफ आपकी नजरें पैनी नजरें हैं। और जो आने वाले वर्षों में जिंदगियों में हम लोग देखेंगे कि जो कुछ तराशे हुए क्षण आपने हमें छान कर दिए हैं, इनको हम लोग अपनी स्मृतियों में संजोएंगे और अपने फिल्म्स में, एल्बम्स में रखेंगे। मैं आप लोगों को धन्यवाद देना चाहूँगा और एक रिप्रेजेंटेटिव को कैमरामैन की तरफ से वेलकम करूँगा कि मंच पर आए और सम्मानित हो। फ्रॉम माय सारे कैमरामैन लोग आ जाइए 1 मिनट के लिए। रजनीश, प्लीज बी हियर। I will request Obaid to hand it over. पहले बोला I will personally thank all those beautiful girls who were here and who helped us in the distribution of the prizes and all the bouquets. मतलब मैं तहे दिल से आप लोगों का शुक्रिया करूंगा कि आप लोगों ने बहुत ही अच्छा काम किया। बहुत खुशी हुई देखकर, और जिस तरीके से आपने काम किया वो बिल्कुल हम लोगों के लिए सम्मान का विषय हो गया। आप लोगों को बहुत बहुत धन्यवाद। आप लोग आइए और मैं आप लोगों को देने के लिए बुलाऊंगा डॉक्टर अर्चना सिन्हा जी, वो आप लोग का ऑनर करेंगे। आप लोग ऊपर मंच पे आ जाओ। आपने हर जगह सबको मंच पर बुलाया है, साथ ले गई हैं, आइए मंच पर आइए। और मनीष जी हेल्प करेंगे इसमें। मनीष हेल्प करो, फोटो लेने में। अच्छा ठीक है, हेल्प करो। मीडिया वाले अगर कोई हो, एनीवन फ्रॉम मीडिया, प्रिंट एंड इलेक्ट्रॉनिक, कोई है? जीजा उसे तो है मीडिया। हाँ, तुम्ही को देते हैं रिप्रेजेंटेशन। सो नाउ फ्रेंड्स, जीजा हुसैन को दिया जा रहा है टू रिप्रेजेंट एज द रिप्रेजेंटेटिव ऑफ द मीडिया पीपल, क्योंकि ये हम लोग के मीडिया मैन हैं, हम लोग के मीडिया स्पोक्स पर्सन भी हैं। और जितनी बातें आप पेपर में देख रहे हैं, इलेक्ट्रॉनिक मीडिया में देख रहे हैं, सबके पीछे इन्हीं का दिल दिमाग काम करता है, कि दिल से जुड़े रहते हैं हमारे साथ। सो फ्रेंड्स, थैंक यू ऑल वेरी मच। Now every one of you is invited for the lunch, which I suppose that is sumptuous as told by Dr. Supriyo Mukherjee कि मटन ने बहुत उसको अट्रैक्ट किया है। अभी देखते हैं अब क्या क्या मिलता है। थैंक यू वेरी मच। फाइनल कमेंट्स फ्रॉम डॉक्टर ओबैद अली।
क्या बोलूं, कुछ समझ में नहीं आ रहा है। सर जब बोलते हैं तो उसके बाद बोलने के लिए बचता कहाँ है कुछ। आप सबों का धन्यवाद। थैंक यू।